Hello. Can we start? Mohammed?
Yes, go ahead, Dr. Saud. Thank you very much.
Hi, good afternoon, everyone. We'll say good afternoon to people from Saudi Arabia, from Italy, from India, and we'll say good morning for the people from United States. I'm honored to chair this session. And to start, I'd like to thank the organizing committee and the scientific committee and the chairman of scientific committee, Dr. Al-Harbi, who made this updates in robotic surgery for the second time. Update in robotic surgery was today, the third day. We enjoyed the first day, which was covered mainly the general surgery, robotic surgery and head and neck ENT surgery, and second day, which was covered the topics related to urology and artificial intelligence in surgery in general, and education and learning curve in robotic surgery. Before we start, we really, as a chairman of scientific board of general surgery in Saudi Commission, I'm honored to see this event and to tell you about the history of robotic surgery in Saudi Arabia. When 2009, when there was only 3 robotic machine in our country, now majority of the hospitals, they have robotic surgery, and we had a lot of fellows who had joined our services in Ministry of Health, universities, National Guard, Armed Forces hospitals, who had training in different countries, North America, South Korea, Australia, India, Italy. So we had variety of people with different experience, which was really added value to our country, and also had a great impact on patient outcome and surgery. I'm honored today to chair this session with my colleague, Dr. Muad Al-Hazza. Dr. Al-Hazza, he's a consultant urology surgery. He's a transplant surgeon. He's associated professor of urology in Imam University. Dr. Al-Hazza, he has huge experience in robotic and minimal invasive surgery in urology. And he has tangible contribution in education in Imam University. I am Saud Al-Rashidi. I'm a consultant general surgery, consultant breast endocrine surgery. Also, I did my training in United States, Tulane University, as robotic surgery. We started doing robotic thyroid surgery. I do adrenal surgery, robotic. And today we'll start our session with Dr. Al-Harbi. Dr. Al-Harbi, he's a very senior consultant in general surgery and colorectal surgeon. Dr. Al-Harbi, he's one of the founders of surgery department in Imam University. Dr. Al-Harbi worked as Vice Dean of College of Medicine, and he has great and tangible contribution on the research in our kingdom and he has a great contribution in outreach program in the Ministry of Health. Dr. Al-Harbi, wherever you go in Saudi Arabia, you will find Dr. Al-Harbi name doing surgery for and supporting the new surgery who had started. For example, last month, I was called by one of the senior consultants in Hayel University, and he told me that Dr. Al-Harbi, he's doing outreach and doing serving patients in Hayel. So Dr. Al-Harbi, really, we are a great honor to have you today, and we'd like to thank you for this meeting, great meeting, and we hope and soon we will have Saudi Society for Robotic Surgery. Dr. Al-Harbi, please, you can start.
Thank you very much, Mr. Chairman. My topic today, I have no financial disclosure, and I have discussion. I have this presentation about the robotic versus laparoscopic colorectal surgery, which is over the last decade was a controversy. Is it feasible to do a robotic surgery or not? So in one study that has been done by Gary Dutch, that has been published 10 years ago, where they started to discuss the feasibility of the robotic for colorectal surgery. As you know, Mr. Chairman, that colorectal surgery is quite obvious in pelvic surgery, like a prostate surgery, bladder surgery, and also the gynecology surgery. So it's quite obvious for a long time, but doing a procedure with robotic for right hemicolectomy, left hemicolectomy with robotic was all the time over the last decade under major discussion. Many meta-analysis has been done. We will discuss it in the coming few slides. But this presentation or this article, it has some records which has been evaluated at 2011 about the start of the robotic surgery. Is it feasible or not? So 216 records has been identified, and 218 records has been explored, where 191 has been excluded by the reviewer because the title of the abstract was not sufficient enough to be in the inclusion criteria. So 10 of them were duplicates. So we end up by 17 articles at that time to discuss the eligibility. And doing the qualitative and quantitative analysis, it has been included as 17 study. So it has been studied at that time that robotic surgery is gaining an interest in general in colorectal surgery. Da Vinci system at that time was in its beginning. I believe it was SI, so it was, then afterwards XI came afterwards. But the current commercial time was tele-robotic technology in the market, which has been postulated to improve the outcome over traditional open and laparoscopic surgery. Then afterwards, there was increased facility which with complex dissection has been performed. So there was a theoretical advantage for the surgeons doing the robotic surgery. And this includes that it's a three-dimensional view allowing complete immersion of the operative field, and a special articulation instrument offering multiple additional degrees of freedom. And it was ergonomic operative position for increased comfort, and it was motion scaling permitting more precise dissection. And as you know, with laparoscopic surgery, the tremor function, or the tremor that may happen to the surgeon, it can be avoided by the robotic surgery in case if there is any. So the theoretical promise of the robotics has not been. We'll discuss that over time. It has become more and more evident, and the current literature didn't demonstrate any measurable difference for the operative and post-operative outcome between patients going for malignant disease who undergo laparoscopic or robotic procedure. So if you see that this slide, that the port replacement and the robotic in the right hemicolectomy, you'll find that there is one port over the umbilicus and the 3 ports in the left lower quadrant. In comparison to the robotic assisted for the sigmoid colectomy, that you will find it as it's almost like laparoscopy. It will be to the counterpart of the right upper quadrant, where there will be one the umbilicus port and one in the left upper, and the other will be in the right lower. So if you can see that the difference, the potential complications, the intraoperatively between the laparoscopic and the robotic, you'll find that there are more complications with laparoscopic related to ileus for the right hemicolectomy. Also, the bleeding, which requires transfusion, has been found that has more with laparoscopy. And I believe the reason for that, the laparoscope, the robotic at that time in 2010 was still in its beginning. And maybe the learning curve was not discussed efficiently because there was no clear definition what is the proper learning curve for the physician or surgeons. And this can be explained why there is a major difference. But you can say that the robotic surgeon, they are more expert. They know already how to handle laparoscopy, so they handle robotic in more ease, and that's why they have less chance to have complication for the right hemi. The same thing applies for the left hemicolectomy, that the conversion rate for the robotic it was 2 compared to 0 in laparoscopy. But in the recent literature, it proves the opposite. The conversion rate for the robotic is less than laparoscopy, and you see in the next slide that there is a change over the last decade, that the conversion rate is lower and lower with robotic, and this explains that there is more and more experience of this the procedure. You can see here that the sample size and the time, the average procedure time, and different literature between comparing the laparoscopy and the robotic, and you can see in the average procedure time that it is almost 174 minutes for robotics, but in comparison to 100 minutes in laparoscopy. So you can see that the robotic is consuming more time. Almost all literature proves that the robotic requires more time, almost double the time of laparoscopy. And again, I believe because of the learning skill and the docking time, most of the discussion was about the docking time is taking too much. So, but I believe over experience and over training and more and more with the learning curve, that it is getting more and more towards less and less procedure time. Again, if we speak about robotics all the time, the cost of the conversion or the cost of the robotic is quite essential to discuss. Yesterday, Dr. Chaudhary from India, he spoke about what is the cost effectiveness of having robotic surgery in the hospital, and he gave a clear answer because his hospital is Apollo, he's a pediatric urologist, and making economic or feasibility assessment of the robotic surgery, it was obvious that if you have 1,000 patients doing robotic each year, that will justify the cost. Because over 5 years with 1,000 patients doing yearly, this will cover the cost of the robotic. But we have to be careful for medical cities or centers that they do not have such high volume of patients to justify to convert the patient from robotic to open technique. This again will increase the burden and increase the cost. Nobody is actually discussing that the robotic has a cost, and it has more cost if there is a conversion to open technique. So the episode payments for open corrective option, conversion to open surgery significantly increase the payment associated with minimally invasive colorectal surgery. And again, this can increase the cost by 50% or 100% over the already high cost. And because of the conversion rate in robotic colorectal surgery, it has half of those laparoscopy. Excess expenditure attributes to robotics are attenuated by the consideration of the cost of conversion. So if we discuss what is the role of simulation-based training in minimally invasive robotic colorectal surgery, studies that have demonstrated an improvement in minimally invasive surgery skills to the actual operating room in the general surgery and stepwise approach to surgical simulation with a combination of various training methods appears to be useful in colorectal surgery training programs. However, the scientific evidence of the transfer of skills, specifically for colorectal surgery, is extremely scarce and very variable. Thus, the evaluation of the results remain quite difficult. So, again, the next question: what is about the initial experience with dual console robotic assisted platform for training and the colorectal surgery? This has been discussed by Bolgar et al. At 2017. The Da Vinci XI dual console platform is safe and effective platform for training junior residents. As you know, we have to train our staff, but the question, do you train them with wet lab or dry lab? And if it's wet lab, do you train them like laparoscopy over patients, or you give them courses before? So again, the training for staff or for residents is still under negotiation and discussion. How far do you go to train your resident before going in? The dual console system has the potential to alter surgical training pathway. So what are the advantages over laparoscopy? If we see that the robotic has 3D view, they have stable camera platform, the use of articulated instrument which make fine dissection more feasible, particularly in a narrow pelvis. And also it has longer operative time, but lower rates of conversion to open surgery. But again, if you go for, you have to check also the hospital stay, is it shorter or not? Again, it is shorter with robotics compared to laparoscopy, but again, the increased cost compared to laparoscopy surgery. If we speak about the conversion rate was almost 0% in robotic group compared to 10% laparoscopic group. And as we said, this is in 2017, and the decade before it was higher. So the conversion rate is almost zero. I believe the reason why is because it's managed by and handled by an experienced surgeon. The serious complication was low in robotic surgery. It was 5%, but in the laparoscopy was almost 20%. It was 4 times higher complication rate. The minimally complete in robotic group, and the circumferential resection margin involvement was not statistically significantly different between the groups. Again, an international multi-center randomized clinical trial which included 470 patients. COLAR trial was the primary outcome for that trial was how much is the conversion to open for robotic surgery, colorectal surgery. The secondary outcome included was intraoperative complication, post-operative complication, circumferential resection margin positivity, quality of life score, bladder sexual dysfunction, and the oncologic outcome. Unfortunately, at this time, the literature has poorly defined what is the learning curve may look like for the robotic platform, particularly robotic TME. That study showed that there was no difference which was seen with regard to conversion to open between 2 groups, and robotic was 8% and then laparoscopy was 12%, while circumferential resection margin positivity was slightly higher in robotic group. It was 6% compared to 5%. This was not found to be statistically significant, and no statistical significant difference were found with regard to secondary outcome. Mesorectal excision TME. for rectal cancer. The rate of conversion to open robotic was lower compared to laparoscopic group. Respectively, it was 11% up to versus 5%. So the conversion rate was between robotic and laparoscopy was significantly important. The shorter operative time was noted in laparoscopic group, and this is quite evident. There was no statistical difference were seen in the length of stay or return to bowel function between the two groups, although when one studies has been shown that, and multiple studies actually showed that there is a shorter return to bowel function with robotics, but this meta-analysis done by Huang showed that there are no differences. It showed also that no differences were seen with regard to short-term oncologic factors, and specifically circumferential margin positivity, distal resection margin positivity, and the number of lymph nodes harvested. Wang et al. Systematic review and meta-analysis, a recent one, 2020. The largest and the most recent meta-analysis on the topic analyzed 20 studies involving a total of 5,496 patients. It showed that the robotic group was associated with longer operative time. And the lower conversion rate to open surgery rate that quite evident. The shorter length of stay with evident with robotic assisted versus laparoscopy, and the faster bowel function recovery and lower post-operative complication. And there was no difference has been seen with regard to oncologic factors, which are the number of lymph nodes extracted and distal resection margin and circumferential margin. I have to remind you that we have almost 3 meta-analyses, first in 2020 and 2010, then 2017, then another one 2020, and each one of them it has different. In general, they are almost the same, but there are minor changes. I believe again that the learning skill is quite obvious to minimize the complication rate in general. If we speak about transanal approach, this is a little bit out from the issue of robotic surgery, but it has been discussed that transanal TME was first described in 2010, and the main reason for that was the narrow pelvis patients and low bulky tumors or obese patients. But the long-term outcome by transanal approach was not as expected as the start. So the TME specimen were complete or near complete in 96% of those patients. Furthermore, 94% of specimen had negative CRM, and 98% had negative distal margin with mean follow-up of 5.5 years with local recurrence rate of 7.4. The transanal versus traditional laparoscopic mesorectal excision for rectal carcinoma showed that it examined 25 patients with mid to distal rectal cancer who underwent transanal TME and matched them with similar patients who underwent laparoscopic resection. They found that 96% of TME specimen in the transanal TME group were complete, as compared to 72% with the traditional laparoscopic group. Oncological factors, including CRM, length of specimen, and distal margin, were comparable between the two groups. So, in Hajbidna meta-analysis, which is a recent one, 2020, which compared the transanal total mesorectal excision versus laparoscopic total mesorectal excision and management of rectal cancer, they complied that 18 comparative studies, which included 1,000 patients who underwent a transanal TME and 1,480 patients who underwent laparoscopic TME. And the transanal approach was associated with a significantly higher likelihood of R0 resection. The larger number of harvested lymph node was noted, and the lower rate of positive CRM. Lower rates of conversion to an open procedure compared with laparoscopic TME. Again, in another multi-center randomized trial, comparing transanal with the laparoscopic TME, which is color 3, primary endpoint is involved in CRM. Secondary endpoints include completeness of mesorectum excision, residual mesorectum, morbidity, mortality, and local recurrence. And Camel meta-analysis, which is a recent study comparing the robotic-assisted versus standard laparoscopic surgery for rectal resection, and they evaluated almost 20,000 patients. The data were pooled using random effect meta-analysis. 42 were considered eligible for the meta-analysis. Survival to hospital discharge or 30 days overall survival rate was 99.6% for robotic and 98.8% for laparoscopic surgery. The time to first flatus and robotic group was 2.5 days and was significantly statistically significant shorter than laparoscopic group, which has 2.9 days. In a case of time to liquid diet, solid diet, and bowel movement, the analysis showed no statistical significant difference. The length of hospital stay in robotic versus laparoscopic group varied and mounted about to 8.0 versus 9.5 days of laparoscopic group. The overall 30 days complication in the robotic and laparoscopic group were 27% and 19% respectively. So in conclusion, the robotic assisted technique provides several advantages over laparoscopic techniques in reducing operative time, significantly lowering conversion of the procedure to open, and shortening the duration of hospital stay, lowering the risk of urinary retention, improving survival to hospital discharge, or 30 days overall survival rate. I think that was the last lecture, the last slide for this presentation. And you are welcome for any question.
Thank you, Dr. Al-Harbi, for a nice presentation. We enjoy it. And thank you for respecting the time. So we have 4 minutes for discussion. If any question from the audience, please. Or panelists. So Dr. Al-Harbi, in early robotic era, there was, or before that, when laparoscopic started in early 90s with rectal surgery and colon surgery, there was a big discussion role of laparoscopy in oncology surgery, and there was a senior colorectal surgery who had refused the laparoscopic for oncology procedures. But nowadays, the standard care is laparoscopic. Do you think in future, near future, robotic will be standard of care for, especially in rectal rectal cancers and deep organ cancer?
I guess, thank you very much, Mr. Chairman. I think we are obligated to follow the international progression of technology to support the surgeon to achieve the best outcome for our patients. And again, the learning curve is getting more and more. I believe we have more challenges regarding economy and justification of the new technology to be implemented to our patients. Despite the international more and more requirement to be precise in our surgery. But I believe the challenges will stay for some time. Yesterday, one of our colleagues, he spoke about a robotic that it has only localized or specific function. It shouldn't be like a Da Vinci would cost you almost $2,000 US. It can be something cheaper and provide a specific function like tying or something like that. I believe if we do more division, the robotic, we may progress faster. With transformation in our country and the economy of our health system, I still doubt that the robotic will expand efficiently. As you know, last year we hosted the first robotic international event. It was chaired by Vipul Patel, the chairman or president of SRS. It is quite clear that in the West, they have a lot of robotic procedure compared to Middle East. But with the economy transformation in our country, I'm not sure are we going to be in the same level that we hope. Putting in consideration that the transformation or the maturity of the senior surgeon in our country, they start to question another question: do we need robotic surgery or telesurgery? I believe there is the first steps nowadays for a national project discussing the telesurgery, because I remember the robotic at their start 2 decades ago, they start to market that the robotic, you can do it, and actually they can. You can, the main purpose of robotic that the senior consultant and sit in a capital, in region A can do the procedure in region B in a different location. And that was the main purpose of robotic all over the world. Of course, it's applied partially, but the second question is it justified to have it or not? It's quite clear that in pelvic surgery and urologic surgery, it has a superior hand over laparoscopy. But to be frank, I'm not sure that we can progress, because we discussed that over the last 2 days. And I believe the last year theme of the discussion was, are we able to reduce the cost or not? There was no clear answer, actually. Actually, the cost is getting higher and higher over years. So I think this is $1 million question. We can answer this partially. But again, you are an expert person, Dr. Saud. You are have a significant position in Saudi Council of Specialties in the program of surgery. So maybe your input also is quite valid for people who are decision makers in Saudi Arabia. What is your opinion? What do you think?
Thank you, Dr. Al-Harbi. I think what you mentioned, we are in a transformational time of, in general, not only in surgery, but health services in the kingdom. There is redesign of healthcare, providing the services to our patients. So we are moving from governmental to private and non-profit organization. I think robotic surgery in one of the biggest conference for the surgery in American College of Surgeons. I remember one of the French surgeon who had big input for colorectal surgery, and he was working on Paris on the, I think, 17th part of France, but I cannot recall the hospital. But he mentioned, I was wrong when I stand up in this place more than 20 years back when I talk about laparoscopic, and my department was far away from people who had started minimal invasive surgery for cancer cases. And I hope we will not stand on the backstage while people in front stage, while they are using robotic. So he was encouraging people to move to direct of robotic. I see the future for telesurgery, but we cannot move to telesurgery if we don't have a good expertise, people who had huge experience in robotic surgery, who had who will be able to control and do surgery from distance. And this is what we needed. We want utilize resources, especially human expert people who had this experience to do surgery from abroad. So if we have one surgeon, for example, in hospital with capacity 500 beds, and he's doing surgery only in 2 days, so this is waste of resources. We have to utilize people to the maximum to get benefit for the patient and for the physician, and to trainee and to train more people with robotic. I am optimistic to the robotic surgery future in the kingdom, and inshallah we will see more robotic and more fellow who will come back. And most of the programs in our country, Saudi programs, they provide a robotic during their training, especially in neurology and general surgery and obstetric, especially in oncology services. Thank you, Dr. Al-Harbi, again. And I'm honored to share this session. Now, Dr. Al-Harbi, he will be the chairperson with Dr. Muad Al-Hazza. Thank you, Dr. Al-Harbi, again. And Mike, on your side. Thank you.
Thank you very much, Dr. Saud. We'll meet again. Thank you very much.
Okay.
Dr. Joel, are you around?
Yes, sir. Good afternoon.
Good afternoon. Just allow me for 1 minute to introduce you, please. Thank you very much, Dr. Nietzsche, and joining us. Doctor, I'll just 1 minute. Dr. Joel, thank you very much. Dr. Joel is an onco anesthetist with a special interest in difficult airway management, robotic surgery, thoracic and lung surgery. He is an expert in the use of bronchoscopic guided intubation, one lung ventilation, and use of ultrasound, anesthesia, and regional block. He is also doing almost all oncology surgical patient with sedation for procedure like intervention, radiology, and radiotherapy, and others. Thank you very much, Dr. Joel. Please proceed. Thank you very much.
Thank you, Dr. Mohammed. Good afternoon, everyone. I am Dr. Nitesh Goyal, consultant anesthesia from Rajiv Gandhi Cancer Hospital, New Delhi, India. I'm thankful to Dr. Mohammed for giving me such opportunity to talk on this platform. Today, I will be talking about anesthetic implications in robotic surgeries. Now, over the past few years, robotics-assisted surgery has become a widespread in a variety of operations. Several robotic systems have attempted to enter the field of robotic surgery. Most commonly available systems in India are Zeus and the Vinci system. Both of these robots are available in our hospital. The setting for robotic surgery requires specific considerations that differ from the conservative surgical techniques, both for surgeon and anesthetist. And that's why the modern anesthesiologist should keep abreast of these changes and consider the impact on the anesthetic plan and patient safety. Nuts and bolts of robotic surgery are well known to us, and as Dr. Mohammed has already explained, the benefits of robotic surgeries in terms of improved cosmesis, reduced wound complications, faster recovery, and shorter hospital stay. It also overcomes the shortcomings of conservative laparoscopy or endoscopic techniques in terms of the system-dependent unstable video camera platform restricted ergonomics of the surgeon during laparoscopy. It helps in better visualization with stereoscopic views, elimination of hand tremors, robotic wrist, you're well aware of, And it also gives good visibility of difficult to reach areas. Over the past 2 decades, the scope of robotic surgery has increased from one system to many systems of the body. For example, robotic surgery in genitourinary part of the body, nephrectomy, prostatectomy, hysterectomy, and for GI surgeries like hepatectomy, gastric surgeries, even in thorax. Nowadays, cardiac surgeries, thymectomy, esophagectomy, and lobectomies are done very frequently. For head and neck surgeries, all the surgeries like tonsil, tongue, head and neck dissections, and thyroid surgeries, they are done with the help of the robot. Not only the part of the body inside the body, some outside structures like breast and lymph node dissection are also being done with robotic machines. Now, why anesthetists is bothered that robotic surgeries are increasing? See, the number and the scope of the robotic surgery is rising, and anesthetist's ergonomic is changing with the robotic surgery. When the patient is in the position for the robotic surgery, hands are tucked in, robot is docked. So it is very difficult for an anesthetist to reach up to the area of requirement, which we'll be talking very soon. Now it's a different surgical technique and thus requirement as compared to laparoscopic and conventional surgeries. Physiological changes occurs during the robotic surgery much more and adverse as compared to laparoscopic or the conventional open surgeries. We may require advanced monitoring. Fluid management is different. And of course, as the number of the cases for the robotic surgery is rising, so does the chance of medical legal issues. I have tried to explain the anesthetic implications in 3 parts for whole of the perioperative process. Preoperative, which include pre-anesthetic evaluation and optimization, monitoring, then type of anesthesia given. Intraoperatively, the main factors are patient position, pneumoperitoneum, site of the surgery, hemodynamic and ventilation parameters, airway involvement or management, and of course the CPCR. And post-operatively, main factors of interest are delirium, cerebral edema, post-op atelectasis. Now starting with the preoperative part, preoperative evaluation. In this concept, we do a systemic review of the patient's history and physical examination of all patients as we do routinely. The main points of concern for robotic cases are age, BMI. Most of the patients coming for prostatectomy or hysterectomy, they are of older age group. And with the old age starts the medical problems. Comorbidities, they have issues with respect to chest, which can help be hampering during the ventilation during intraoperative period. Also, we have seen that most of the old age patients, they does not wake up very brightly after the surgery, may have emergence delirium or drowsy, and may land up with the ventilation, post-op ventilator support. Similarly, for the obese patients, all those patients having a respiratory system abnormalities with respect to lung diseases, interstitial lung diseases, they might have a problem when we are ventilating during the intraoperative period as the pressure rises and patient may land up in hypoxia or hypercarbia. Similarly, all those patients having cardiovascular issues, angina, cardiac compromise, they may have a hemodynamic variability very much during intraoperative period and they need a proper management. Patients with a history of stroke and TIA, any patient with a history of recent surgery and glaucoma, they also have a propensity of having a transient ischemic transient vision loss post-operatively. And to complete the list, comorbidities like diabetes, hypothyroid, any history of medication, and surgical anesthetic history. Apart from routine examination and hemodynamic examination, we should have a thorough airway examination, because as I'm going to tell you that due to ergonomics, we won't be able to handle the airway very easily in the intraoperative period. So we have to plan accordingly, preoperatively. Any patient auscultation of the respiratory system is necessary, because if a patient is suffering from any asthma, bronchitis, having wheeze, decreased airentry, that those patients need to be optimized. Preoperative optimization is necessary for all those patients suffering from respiratory or cardiac problems, so that we can have a good ventilation during intraoperative period, good maintenance of hemodynamic variables like blood pressure and pulse rate, and patient may come out of the surgery very brightly without any hypoxia, hypercarbia, emergence delirium. All those patients having a history of glaucoma, they should be treated with the anti-glaucoma drugs, because during intraoperative period, they are bound to have a high intraocular pressure, which is a well-documented fact, and they should be optimized preoperatively. We have to plan the monitors with respect to EKG, plethysmography, non-invasive blood pressure monitoring, and tidal carbon dioxide should be done. Depending upon institutional protocol, invasive monitoring can be done, but we recommend to do monitoring for depth of anesthesia. Any monitoring you can do, like we have a BIS, bispectral index monitoring, or entropy can also be used. Coming on to the type of anesthesia, most common mode of anesthesia is general anesthesia. Regional is given only in cases if surgery is done below the abdomen, like veil. There, epidural with sedation can be used. For pain, we use opioids or non-steroidal anti-inflammatory drugs. Epidural block may or may not be used depending upon the protocol of the institution. For general anesthesia, we usually prefer TIVA, total intravenous anesthesia, or propofol-based anesthesia. Coming to the intraoperative part. Now, some of the general aspects. Spatial restrictions of the anesthetist due to the bulky equipment is there, because after the robot has been positioned during the surgery and engaged, the anesthesiologist is unable to readily access the patient. Thus, any lines, monitors, and the patient protective device must be placed beforehand and should be secured to ensure no kinking or displacement. It is impossible to allow changes in patient position or any kind of access to the patient if the robot is not detached first. And because of this time delay in patient management, it may result in a critical complications. This fact is very important when it comes to emergency situation during intraoperative period leading because of bleeding or patient having bradycardia or cardiac arrest. Now, according to the type of surgery, robotic surgery may require surgical positioning that is relatively extreme and steeper than the other conventional or laparoscopic surgery. We'll be talking them about very soon. Access to the airway may be difficult, almost all types of robotic surgery, and use of carbon dioxide may cause complications like subcutaneous emphysema, pneumothorax, as in any laparoscopic surgeries. Now, as I told, the type of anesthesia is general anesthesia, TIVA, total intravenous anesthesia, or propofol-based anesthesia. Propofol-based anesthesia means we are using oxygen, inhalation agent, and a propofol. Whereas in TIVA, we use either pure propofol with target control infusion pumps or an infusion of opioid, remifentanil or sufentanil. Injection dexmedetomidine infusion can also be given to augment the type of anesthesia and help in maintaining the depth of anesthesia. For pain, opioids and NSAIDs are used. We should also do the neuromuscular monitoring for adequate muscle relaxation, because if the patient is not adequately relaxed during the surgery, his movement may cause injury to the surgical part where the surgery is done or to the other contents of the body. Now, these are some of the common positions for the robotic patients, like Steve Trendelenburg, lithotomy, lateral with break of the table at the chest, semi-prone, and head and neck surgeries. Here you can see this patient is lying in a steep Trendelenburg. Steep means more than the conservative laparoscopic head low position, that is around 45 degree or 30 degree. This is almost like 60 degree with a lithotomy. What happens? The problem is when the patient is in this steep head low position, apart from physiological problems, patient may slide down. So for that, you have to strap the patients. And in our institute, we try to use a shoulder support here along with a gel pad, so the patient does not fall and does not have a brachial plexus or neural plexus injury. Here you can see the lateral position with the break at the chest. This position is commonly preferred for robotic pneumonectomy, or if expansion is done at the lower rib cage, is done for nephrectomy. Now, all these positions have their own complications on factors. We'll be talking about them very soon. Here we can see the robotic transoral robotic surgery. Though tracheostomy has been done in this patient, most of the patients have a sharing of the airway because we do the nasal intubation and the robotic surgery is going on from here. Now, steep Trendelenburg and pneumoperitoneum, this type of position causes abdominal contents to move carefully, which causes FRC and lung compliance to be reduced, ventilation perfusion mismatch, which can lead to post-op atelectasis and pulmonary interstitial edema. So to combat this, we usually applied PEEP of 4 to 7 positive end expiratory pressure and try to ventilate the pressure not more than having a airway pressure of 35 to 40 centimeters of water. Also, to overcome the negative influence of steep Trendelenburg position to the lungs, use of pressure control ventilation results in greater dynamic compliance as compared to the volume control ventilation. Though it is a very good to use a pressure control ventilation, but the problem is if you are using it very frequently. Now, during the robotic surgery, if the assistants do the suctioning at the abdominal part, and if the abdominal pressure is not maintained constantly with the help of pneumoseal, this pressure control ventilation can cause increased delivery of the tidal volume, which can in turn cause volutrauma, barotrauma, or may cause the injury at the surgical site because it tends to move the intestine towards the surgical site. So that aspect has to be kept in mind. Also, this position causes movement of the diaphragm towards the neck, and thus the distance from the vocal cord to the carina may be reduced by about 1 centimeter, which can lead to endobronchial intubation. So we have to make sure the intubation, after intubation, that the tube is placed properly and the tip is at least 3 to 4 centimeters above the carina. Now, in steep Trendelenburg position, we see that increase in central venous pressure, pulmonary artery pressure, and pulmonary capillary wedge pressure, which in turn decreases the heart rate. Now, this fact gets aggravated when we are insuffling the carbon dioxide into the abdomen. We have seen bradycardia and even heart asystole during this phase. So it's better to be ready with glycopyrrolate or injection atropine. And first, in this situation, you should tell the surgeon to stop the insufflation, deflate the abdomen, wait, and again do the insufflation. If the condition again, you should give an injection atropine or glycopyrrolate. Of course, the depth of anesthesia is very much an important aspect. It should be maintained throughout that procedure. Also, we can see the increase in systemic vascular resistance due to sympathetic response of peritoneum stretching and increase in cardiac output and volume, cardiac index. Thus, normally what happens due to the head-low position, we think that the patient will have a increased venous return, which will cause increase in blood pressure, But this does not happen actually, because due to the venous return may be increased, but due to the pneumoperitoneum, aortic compression occurs, which in turn causes increase in SVR. So all these factors combat each other, and we can see a lot of hemodynamic variability. And that is why all those patients who are cardiacally compromised, like with angina or low ejection fraction or anything, they can have a negative impact on their heart. So we should optimize those patients accordingly to avoid this situation. We also see clinical swelling of the face and the upper airway with the venostasis in the head and neck during this steep Trendelenburg and pneumoperitoneum position. For this, we should try to give a restrictive fluid management, although restrictive fluid management is also required for some other factors we'll be talking very soon. But this has seen to be beneficial in decreasing the swelling on the face. And we should also consider that before extubation, that if we are suspecting any chance of upper airway edema, because once the patient is extubated, they may again have a stridor and may land up in hypoxia, and we may need to intubate again. So this should be considered well before you are extubating a patient. Now, Trendelenburg position also increases the intracranial pressure and intraocular pressure. These are well documented facts, and various studies have been done. The steep Trendelenburg position is also prone for devastating ischemic optic neuropathy and corneal abrasions. So due to the head-low position pneumoperitoneum, we can have a transient loss of vision in post-operative period, especially those patients having a glaucoma. So you can give an injection LASIK intraoperatively so that the intraocular pressure decreases, or you should treat them pre-operatively by giving anti-glaucoma drugs. To prevent corneal abrasions, it is recommended to tape the eye with a transpirative occlusing dressing. Some people may also do after this padding of the eyes. Now, steep Trendelenburg position itself causes the fall of the patient towards the head, as I told you earlier. So the patient should be properly padded, cushioned, and you should make sure that the patient is not getting any side directly touching to the table part or the hard part. Otherwise, they will have a neoplasia and may complain post-operative period weakness of the upper limb or lower limb. We generally use silicone gel pads apart from the shoulder support. In the head low position, patient's arms are generally tucked inside. Now, pneumoperitoneum itself, they have their own problems, as in laparoscopic surgeries. Carbon dioxide insufflation can cause venous air embolism, subcutaneous emphysema. Though these problems get resolved after the insufflation is stopped and pneumoperitoneum is removed, we should mechanically ventilate the patient for some more time so that the hypercarbia can be removed. Otherwise, patient will have an excessive work of breathing. Possibility of pneumothorax or pneumomyosium should also be considered if there is damage to the during the surgery of the diaphragm, because that gas can move inside to the thorax. Now, this I was talking about due to the ergonomics of the patient, because the patient is docked in head low position with everything tucked in, strapped tightly. If due to some reason for gas embolism or any bleeding, you have to open up the patient or you have to do the CPCR, it becomes very difficult. It takes time to de-dock the patient, move the patient, make the patient again on a supine that is parallel to the floor so that you can give a proper cardiac massage. So for that, we recommend that surgical team should practice the emergency drill for de-docking the robotic system if necessary to prevent a delay in resuscitation. Now, all those patients undergoing head and neck robotic surgeries for thyroid, tonsil, neck dissection, etc., the main implication is with respect to the sharing of the airway by both the surgeon and the anesthetist. In most of the patients' surgeries, patient's airway is situated much far away from the anesthesiologist and the machine. And thus, if any damage of the tube or cuff rupture occurs, it again takes time to de-dock and then change. So that's some tricky part and a cumbersome thing. We also find that patient have a high sympathetic response, increasing the BP and pulse rate due to excessive stretching of the oral cavity for doing the surgery. There are high chance of glottic edema and dental injury. The eye should also be secured in these patients specifically because the surgeon is working at the head end and robot arms are also there. There is a high likely possibility that they are putting their hands on the eye and cause a damage to the cornea and the eyes. Now, this semi-prone position is generally done for patients undergoing robotic esophagectomy or pneumonectomy. Anesthetic implications are mainly of one lung ventilation, but some surgeons use artificial pneumothorax. They insufflate the CO2 in the thorax. Now, this in turn decreases the ventilation of the patient. Patient is already in VQ mismatch, which increases with this artificial pneumothorax. It also gives pressure on the heart, causing decrease in cardiac output and fall in blood pressure. So that can be implicated and seen with the hypotension and pulse rate down. Patient may have a hypoxia because inadequately ventilated and hypotension is there. So you should manage accordingly by giving PEEP and to limit the amount of a pneumothorax by consulting with the surgeon. There is also a risk of damage of trachea and bronchus because they are doing microsurgery. 2 or 3 cases I have seen during in front of me only. At that time, we have to open up and do a tracheotomy. Now that thing becomes tricky because the patient is not able to, we are not able to ventilate the patient. It is air is getting leaking out of the damaged trachea. So that we have to see. As I told you, restricted fluid therapy is important for intraoperative fluid therapy for multiple reasons. One, if we are giving high amount of fluid, it causes engorged vessels, which can cause bleeding, which is very much magnified at the robotic view. Also, it increases cerebral and glottic edema. Third, if during the surgery there is very much almost nil amount of third space loss, so there is no requirement of giving out the fluid. Any change in hemodynamic parameters should be managed with vasopressors or vasodilators. Both hypo or hypotension can be seen depending upon the condition, patient, stage of the surgery. So you have to manage accordingly. Think about the facts about like fluid deficient is or not there, sympathetic response, if the patient is in light plane of anesthesia or pain, and then you manage accordingly. Ventilation, as I told you, pressure control ventilation is good, but you have to make sure that the you are using pneumosil to maintain a exact abdominal pressure to prevent any more hyperventilation causing volume or barotrauma. In case of obstructive lung disease, you may have a high airway pressure and end-tidal hypercarbia and hypoxia. Now coming to the post-operative period. In post-operative period, important thing we see is emergence delirium, and it is mainly seen in case of old age patients, chronic smoker, chronic alcoholic. To combat thing, we try to optimize if pathology is there preoperatively, and intraoperatively we have seen that the role of intraoperative injection dexmedetomidine, all those patients which we are put on these during intraoperative period, they wake up very smoothly and has a less percentage of chance of getting into emergency delirium. It is mainly implicated to cerebral edema because of head location and the fluids. Apart from this, after post-extubation, there is a high chance of patient having a post-op atelectasis causing hypoxia. So intraoperative PEEF should and must be given. You have to also take care of the pain either with the opioids or the blocks. Now, post-extubation respiratory distress is a known complication, and it is seen that airway complications such as stridor, laryngeal edema, obstruction, and tracheal division may result in post-operative respiratory distress. In roughly 0.7% of robotic surgeries requiring post-operative re-intubation. So it is recommended to do a restrictive fluid therapy and then ensure that the patient can be breathed around the endotracheal tube with a deflated cuff in any of the patient you think that might land up in this situation. Now, for obese patients, it's a boon because frankly speaking, post-operative period is very good for obese patients if they have a successful surgery because the hospital stay is less, infection rate is less, recovery is fast, but intraoperative period is very challenging for both for anesthetist and surgeon. Though we have a separate course for obese patients, but intraoperatively ergonomic with respect to the table, lifting of the patient, ventilation management, all are very cumbersome, and then they have to manage accordingly. So in the end, I would like to say that robotically assisted surgery will likely to play an increasingly large role in the future of surgical practice. The technology of robotic assistance has overcome the limitations of conventional laparoscopy. Anesthesiologists must be aware of these changes and adjust their practice in order to provide safe patient. It's a team approach, that's important. It's a team approach, management involving both surgeon and anesthetist. Both have to understand each implication challenges of each other. It's a challenging anesthetic management as the surgical challenge is there. We should also do auditing for long-term complications to improve the technique. And I'm thinking that introduction of artificial intelligence is going to bring more changes, and we have to do updation accordingly. And that's all for today. Thank you very much. If anybody has any questions, they can ask.
Yes, thank you very much, Doctor. It's really impressive. Yesterday, there was one of the speakers who present his experience on laryngeal cancer, and he was doing he was from Taiwan, Professor Twing, and he explained his experience how it is precise to do robotic in the pharynx. At the same time, there is a tube. It was so precise. But what is your experience about doing thyroid surgery or esophageal surgery or pharyngeal surgery with intubation? How difficult is that?
As far as the thyroid surgery, the intubation is normal. We do the normal oral intubation. We have to expose the neck. So the only thing in case of thyroid surgery is it's a prolonged duration, and surgical exposure flap that has to be taken care of. When it comes to pharyngeal surgery, the tube, we have to do a nasal intubation. Now it becomes a sharing of the airway with the surgeon. The main problem occurs if we have inserted a bigger tube, size tube like 7.5 or more than that diameter tube. It hinders with the area of the surgical for the patient, for the surgeon. So we have to insert a smaller size of tube. Now, during surgery, it is very much possible that they injured the tube, ruptured the cuff part, and the tube might got damaged. So we have to be vigilant with respect to the ventilation, because we are having our capnography. If at all we see that there is a loss of capnography, the ventilation is lost, we should immediately warn the surgeon, dedog the patient, put a BG, check any circuit disconnection, put a bougie and intubate the patient and change the tube over the bougie. For esophagectomy, the anesthesia part is like one lung ventilation, because we have to do a thoracic surgeries. So we insert the DLT. The main challenge is position. It's a semi-prone position in which there is a high probability that when we place the patient semi-prone position, the DLT tends to come out very easily. And also when artificial pneumothorax is done, patient land up in hypotension, we have to start vasopressors. Patient have a hypercapnia, hypoxia, so we might have to increase the tidal volume, tell the surgeon that you decrease the pressure. But otherwise, by doing all those maneuvers, we have all the things with us, like ventilation and drugs. We get out successfully. It's not an issue.
Well, thank you very much, Doctor. It's really a pleasure joining us. I'm really grateful for your efforts, and I'll be in touch with you soon, hopefully.
Definitely. Thank you, sir. Thank you.
Thank you very much. Our next speaker is Dr. Sakalini. Available, Avnish?
Yeah, I'm around, man.
Oh, how are you, Doctor?
Hi, Dr. Ravi. Good to see you again.
Okay, dear participants, Dr. Sakalini is our partner from India. He's an associate professor in colorectal and robotic surgery in Tata Memorial Center, Mumbai. And Dr. Sakalini, he enters oncology surgery program in 1996 up to 2000. He's a senior consultant. And he, after his fellowship in laparoscopy and colorectal surgery, he spent a year as robotic colorectal fellow at UNC University in Seoul. Dr. Sakalini is a well-known expert robotic surgeon in India. Thank you very much for joining us again, Dr. Sakalini. Please proceed. Go ahead. Thank you very much.
Thanks. It's a pleasure to be here. I'll just share my screen. Okay. Good evening, everyone. My talk today is robotic in extended resection for rectal cancer. I think we all know for locally advanced rectal cancer, total neoadjuvant therapy or chemoradiation is the standard of care. And depending on what the outcomes are, you can have a clinically complete response where sometimes patients could go on wait and watch options. If you have good response, then they could go for TME. But however, about 30% of the patients in India, even after TNT, their mesorectal fascia remains positive. And then you have to do more than that. You have to do either extended TME or beyond TME. You may also have lateral pelvic nodes. Lateral pelvic nodes are nodes along the internal iliac vessels. So if their diameter is more than 7 mm, they require neoadjuvant therapy. And even after chemoradiation, if they are more than 6 mm for obturator and 4 mm for internal pelvic, they require lateral pelvic node dissections. So what is the difference between extended and beyond TME? Beyond TME is you actually remove everything. So it will be total pelvic exentration where you remove the bladder and prostate along with the rectum. For if you have rectal cancer invading the uterus, it can be a posterior exentration. You can have an extra levator APR and sacrectomy as well. Well, sometimes if it's only seminal vesicle involved or prostate, then you can do an extended TME where you can take out only the seminal vesicles. You can take out only the prostate or lateral pelvic node dissection. So all of these are slightly more complex and robotic can help in a way. So I think we had this paper for state-of-art surgery for recurrent and locally advanced rectal cancer. So you can see in this diagram, so you have the rectum, which is there posteriorly. So if the tumor goes anteriorly, which is the whitish area, seminal vesicle and prostate, that is the anterior margin which is threatened. When it goes into the lateral pelvic node or the red shaded area there, then you have to do lateral extended dissection. Whereas posterior, you may have to take out the bone, extra levator APR. So that's a strategy for most of them thing. So when you decide you want to have an extended or beyond TME, you have to look at which section is there, anterior, lateral, posterior, or sometimes all of them may be there. So let me show you a video of total pelvic excenteration robotic. So the standard approach for us is normally to dissect along the inferior mesenteric vein, the left colic artery. You dissect along the mesocolic fascia. Next you do is take the inferior mesenteric artery, and then you go along the plane. Once you've defined both IMV and IMV, then you take it beyond the left colic. You go into the pelvis there along the TME plane. In exentation, you will sacrifice the hypogastric nerve, but the plan is to have one plane identically. Here you free the sigmoid laterally. So the first part of the operation is exactly the same. The second part includes the part of lateral pelvic node dissection. We define the obliterated hypogastric, the median and lateral paravesical space. This is the obliterated hypogastric. So here you're going to do dissection. Here you're taking out the external iliac and obturator nodes. The external iliac vein is exposed. You will have a communicating branch between the obturator and external iliac vein. You define the obturator nerves. And you do it on either side. So you define all the branches of internal iliac vessels from either side. In such a way, the obturator nerve gets free. Once you have removed the branches, then you follow all the branches of internal iliac. This is the obturator vessel which is going there. To identify both the internal iliac artery and vein, you probably need to, S234 has to be resected, and you can see the vein very clearly. Here you can see all the branches of internal iliac vessels. Here the deeper branch, which will go to the inferior vesicle. So you can take out individual branches. This is just to demonstrate how the lymph node dissection along vessels can be done, even if they are preserved. Once you do all this, then you start taking all the branches. This is the superior vesical and obliterated hypogastric. Then you'll dissect lower down and you take out the deeper branches as well. Once you've taken all the branches of internal iliac artery, then you'll transect the ureter and mobilize it well enough. After this, the rectum transection is done, lateral pelvic node and all the bladder pedicus have gone. Then you will take the bladder down. So for exenteration, it involves resection of the rectum, the bladder, taking the specimen out through the perineum, formation of ileal conduit, and plastic reconstruction. So it's the longest surgery. So here you can see you've reached the pelvic floor there. You can see the prostate at the border of the levator. For total pelvic exenteration, you may not need to take the dorsal venous complex exactly from the top end. You may want to, or you can just take it from below when you transect the specimen. If you increase the pressure of pneumoperitoneum, then you probably may not need to take a stitch as well. What we normally do is we put a pack anteriorly and posteriorly. Here the prostate is being mobilized over the levator. Because it's a surgical oncology division, even all the adjacent organ dissections were done themselves. So we will put a pack anteriorly and then we divide the rectum. Because we have to form the conduit intracorporally, we put a hemlock clip and suspend the rectum. The root of the small bowel mesentery is mobilized because then it's easy to form the ileal conduit. So when you're doing, you'll identify the length of small bowel 15 centimeter from the IC valve and measure the ileal conduit, and you'll mark it with clips. We normally use white cartridges now to make about 20 centimeter loop of the ileum for an ileal conduit. A small bowel anastomosis is performed intracorporally. Actually, with the use of new robotic staplers, I think this procedure is become quite easy to do. I think Dr. Somashekar, who's presenting next, is going to talk about it. He was the pioneer for robotic staplers in India. And after that, we form an ileal conduit from inside, P by advancement is done. And that's a specimen there. And sometimes when you do an intracorporeal conduit, now this is another case where now this is a neuroendocrine carcinoma. There's significant mesorectal node, and which is touching the mesorectal fascia, and it is very close to where you'd have those lumbosacral trunk. Using neoadjuvant therapy for neuroendocrine carcinoma, the node still remains positive. So the plan is to do an APR, do a lateral pelvic node, and cut the levator at the origin of lumbosacral trunk. So again, you're doing lateral pelvic node dissection. The first part is to identify the ureter, mobilize the ureter. The ureter goes medially. It will dissect in such a way the ureter and the hypogastric nerves are in the same plane. So you dissect along the ureterohypogastric fascia. Then you take up the glands along the iliac vessels. I think robot gives you gut control, but you need good energy devices as well for lateral pelvic node dissection. So if you're going to use monopolar, then sometimes laparoscopy is probably better. So the branches of internal iliac, you cut the obturator artery. So as you follow the obliterated hypogastric and define the paravesical spaces. The obliterated umbilical artery is divided because it gives you more space so that you can follow the deeper branches. So here you can see the superior vesical artery being clipped as well. Once you cut the obliterated thing, then you can actually follow the deeper branches of internal iliac artery, which will be the pudendal and inferior vesical. Sorry, the video looks a bit faded. I think the learning curve for lateral pelvic node dissection is a bit long, maybe 17 or 18 cases, so it takes some time initially. And most of the time when we do node dissection, they are after boost radiotherapy or chemoradiation, and it gets more and more difficult. So once you've done that, then you follow the deeper branches. So you can see the lumbosacral trunk, and that is the point where you will see the size. Here you'll divide the internal pudendal artery, which enters into the sciatic nerve. So that is the ischial spine there. So once you identify the lumbosacral sunken pudendal, you can cut the ischial spine. So the origin of levator at the origin is cut. Even if you do extra levator APR, you can't cut the origin of levator. So this is the best approach. Here you can define, this is the hypogastric nerve, which can be seen very clearly, one from this side and one from the other side. So even for this extended resection, you can try to save the nerve there. Then you can try to connect. This is the middle rectal artery. So you normally don't see the middle rectal artery that well if you're not doing extended resection. Then you go posterior and you cut the levator from where you cut laterally to posteriorly. You'll have internal pudendal artery coming up there again, and you'll divide it. once you do that, then you do a standard procedure where you cut the peritoneum anteriorly and define the seminal vesicles. So you divide the levator completely from all sides, so you'll have a good specimen. And hopefully a margin will be free. So sometimes in the cases that you want to do an extra levator APR and the disease is very close to origin of levator, you do lateral pelvic node dissection, cut the ischial spine there, and then you can define. Then you put a sponge in the behind there, put the lateral pelvic node in there, transect the rectum. And then you can do an extra levator supine APR using DBUS. We cut the coccyx as well. Initially, we used to do a lot of extra levator APR prone, but you can do the same thing in supine if you have good retractors. We use DBUS for good retraction there. And you can even do a prostate say. So here you can see the origin of levator. And that's been a good excision. So this chap is doing well. So the difference is, this is an example of TME itself, and that looks very straightforward. You go in the TME plane, really good. So when you're doing TME, you're actually seeing all the planes and nerves and vessels. This is good pre-sacral fascia. For all palpable tumors, you go down to the pelvic floor and you define the levator or the V of the levator. So even if you're not doing intersphincteric resection for good single cartridge stapling, it's better to define the V. Next time is to do an anterior cut and cut the denonvillous fascia to have a good view. You can lift up the denonvillous fascia as well, and you can preserve the neurovascular bundle. And once you define the section or identify the location of the tumor, then you can staple it. Sometimes if the disease is only involving the prostate, what we can do is we can only resect the prostate and do an APR instead of exentration, and you can leave a suprapubic thing. So this is a 34-year-old male with a lesion 3 centimeters from anal verge, and it is involving only the prostate and seminal vesicles. So instead of doing total exentration and forming complications of ileal conduit, here, after the normal TME, we define the seminal vesicles on either side, take the branches to seminal vesicle, and leave the seminal vesicle on the prostate. So you do anterior dissection as much as down so that you can see the prostate. You have to see the bladder completely. So the plan is to leave the bladder intact, take the seminal vesicle down and cut the prostate. So here you separated the seminal vesicle from the bladder there. When you're doing this sort of surgery, it's good that the patient ejaculates, otherwise sometimes the seminal vesicles are so bulky and it takes an awful lot of time. So once you free the seminal vesicle completely up to the prostate, then you can take the bladder down. So here in unlike like an exentration, you're not going to excise the bladder. So you'll go down to the pelvic floor there, and then you'll divide the prostate from there. So this part of the operation where you're just going to divide the prostate but leave the bladder in place. You can do it like a normal prostatectomy and do a vesicourethral anastomosis, but most of our patients have also got involvement of urethra, so we can't do that. So he immobilized out completely. And what you do is you can cut the neck of the bladder. So the prostate is divided. The bladder is left intact. We haven't taken any pedicles of the bladder there. So it is very important to cut at the neck of the bladder without damaging any of the ureteric orifices. So here's a sagittal view to say the bladder is being intact, the prostate and the seminal vesicles will go along with the rectum there. Next, what you do is you've left the prostate down there, the bladder is intact, you close the neck of the bladder. If the urethra has enough length, then probably you can do a vesicourethral anastomosis. But in this case, if we are suspecting problems with continence, we put in a suprapubic catheter from here and hitch the bladder up again. The semen is taken out from below and then do that. We have done more than 100 MIS pelvic excentrations or so, and maybe the largest series in the world. So we published a paper in BJS Open comparing a 3-year oncological outcomes. So that time it was 60 MIS and 97 open. It obviously took a bit longer for MIS excentration, but the advantage was the blood loss was significantly lower in MIS excentration. There was no significant difference in 3-year overall survival, local recurrence rate, or DFS. So I think in countries like India, we see a lot of locally advanced cases. If you have a high volume center and you do TME, so we do more than 600 TMEs or so per year, you can probably do extended resections using a robotic system. Thank you very much.
Thank you very much, Dr. Sakharini. It's really impressive. How does the robotic change major surgeries from open to robotic with the skills that you have and your center have, make even I think the complication rate is higher. Do you do such cases? Do you do as a combined team with urology in case of bladder involvement of tumors, or you do it solely as a surgical oncology?
I think if you're doing total pelvic excenteration or seminal vesical excision, then we do it solely as a surgical oncologist. But if you're going to do only prostatectomy, or we're going to do prostatectomy with vesicourethral anastomosis, then we can get them involved. But if you're doing an excenteration, then all the ileal conduits are done by us itself. That is it. So I think that's not much to preserve things. So if there any preservative surgery required, like if you're going to take only the prostate and join the bladder to the urethra, like a prostatectomy, then we get the help. Otherwise, most of the time, all of this is done by ourselves.
How is the pelvic excenteration experience in India and of course your center? In general, it is not, to be honest, it's not routinely done over here. I believe because of the high complication rate, plus maybe lack of experience. But how do you think your this procedure in India and your center? How common is it? How are the complication rates, etc.?
So I think we do about 4 a month at least for these excentrations, at least MIS, all excentrations and all. So the morbidity rate is 30% or so, but because we have done about more than 270 or so, so we've got a learning curve now. The most common complication, the small bowel anastomosis leak, is very less. You have a urinary leak rate of about 7.8%. but we have a good intervention radiology. We are also part of the pelvic multicentric group. So what we do is we put in PCNs, and the policy is now if you have a urinary leak, you don't need to take immediately. You just put a PCN and let the urinary drainage do, and do anything that needs to be done has to be done over 6 to 8 weeks. The other complication that can happen is because you've done exentration, the small bowel loop falls into the pelvis and causes obstruction. So we have avoided empty pelvis syndrome by using something called as Bakri balloon, which is used by the gynae. So we put a 500 ml balloon in the pelvis, so the bowel doesn't fall into the pelvis. So the obstruction and immediate complications are gone. So even if you want to redo surgery, it's easy to do. And we start deflating the balloon by about 7 or 8 days or so, and we take it out at 11 days. So I think it's a big hospital. We have intervention radiologists, we have a good support system. And because the volume is high, we do about 15 to 20 colorectal cases per week and more than 10 to 12 rectum every week. So because the volume is high, we are able to manage, but it is high morbidity. It takes a whole day because it includes formation of plastic surgery as well. And the cost is expensive outside as well. So in high volume center, and if you have experience and learning curve, so we are looking at learning curves, and it is there definitely. But outside in individual centers, I have to say, so we would recommend normally sending all these patients here. So ours is the referral center for all recurrent cancers and advanced cancers. So we do 3 to 4 extended resections per week anyway. So either seminal, vesical, lateral pelvic. Like this week, we have done about 4 lateral pelvic node dissections, including 2 robotics. So because of the cases that we get, so we are getting better. But I have to say in the Western world, this is uncommon.
How does the new adjuvant radiotherapy affect your dissection? Does it affect your plan for dissection, or does it?
Okay, I mean, that's the golden mark. So once you have downstage the tumor, so would you plane of resection change or not change? I think most of these, if it was a T4 tumor and you were able to do a TME, we would do that. So we normally based it on the second MRI itself. So most 90% of our patients are operated after chemo radiation, though that's okay. But the radiation oncologists are getting more and more aggressive. They're giving TNT, and they are using boost radiotherapy for the pelvis. So now sometimes people who we operate on them, these lateral pelvic nodes, they are not getting 5,400, they're getting 7,500, and those are difficult ones. And so sometimes you can have problem. You can have a lot of problems and some neuropraxia or lymphocele there, but you have to give the best option. We are all working for the patient. They are trying to cure them with radiotherapy. We are doing surgery. So sometimes we have a give and take sort of thing. So we have to accept some complications for progress. So I think it's all multidisciplinary approach and teamwork there. And we have a great team here.
So in radiotherapy, you go for 4,500 to 5,000 rad before doing your surgery. And this will minimize, I believe, the dissection challenges. Is that right?
That's right. That's right. So, and sometimes we were giving, suppose if they didn't respond to radiotherapy, initially we were giving chemotherapy as well, 4 cycles of Capox, but then a lot of them were progressing as well. So the thing is now, if they have not responded to radiotherapy, should you give consolidation chemotherapy? So I think we looked at data now. So the idea isn't great. So if you can operate and the margin is positive with exentration, there is no point in giving additional chemotherapy. If you've already given TNT, then it's okay. So I think we're learning every day.
Thank you very much. The next question is, the borders of India open for tourists or not yet?
Yes, of course. We are having meetings all the time. Next weekend is a great meeting in Mahabalipuram by Coloplast, and a week after we're going to Northeast India. So you're welcome to come to India. Good food. We are open for business. Thank you very much.
Okay, thank you very much.
Take care, Dr. Alrabi. Good to see you.
Thank you. Bye. I think we will move to our next speaker. Is Dr. Mats. Dr. Mats Brandstrom. Admin, please change Dr. Mats Brandstrom to the panelist so he can share his slides. Dr. Mats? Yes, Dr. Mats, are you able to, please admin? Yes, you are one of the panelists now, Dr. Mats. You can open your audio and your video.
Okay, hello, hi.
Oh, hi, Max. Nice to meet you.
Thank you, and nice to be here. And so, should I start with the talk and share the screen, or yes?
No, yeah, just 1 minute to introduce you. Thank you very much, Dr. Mas Brandstrom from, I think, from Sweden. Is that right? Not USA.
Sweden is correct. Yes.
Yes. Dr. Mats is an associate professor in obstetric and gynecology, University of Gothenburg, and he's an associate professor in physiology in University of Gothenburg. Dr. Mats, he's the chairman, Department of Obstetric and Gynecology, Institute for Clinical Sciences, Saligrineska Academy. If sorry, did I pronounce it right?
Yes. Okay. Yes.
University of Gothenburg, and he's a professor of Department of Obstetric Gynecology, Institute of Clinical Sciences, Saligrineska Academy, University of Gothenburg, and he's a senior consultant and reproductive medicine in the same university. Dr. Mats is a senior consultant. He is well known globally for his efforts in robotics. Thank you very much, Dr. Mats. It's an honor that you are joining us to share your experience. Please go ahead.
Thank you. I will share my screen. So I just having a little problem to get it on here, so I will see here. I cannot share the screen. I don't see here. Let's see.
It's the green button at the bottom.
Yeah, I'm trying to do that. It's preventing me from sharing the screen. We'll see.
Not sure, Dr. Mats. We will wait for Dr. Mats just to give him a few minutes. Yes, he's back again.
Again? Yeah.
Yes, you are back. You can send me by email your lectures. I'll present them from my side. Then you can.
Well, I mean, it should work. So I don't understand why it doesn't work. I'm very sorry here. Can you see it now? No?
No, not yet.
Because it's something wrong with it. Will not. My browser is preventing access to your share screen. Oh, this is it's never happened to me before. Okay, now I may see here if I can find it now. See, it was blocking here. We'll see. This is something. I'm very sorry. Because I don't understand. This never happened to me before, but I cannot share it because it's blocking here. So I don't know what to do. I can send it to you by WeTransfer. Should I do that?
Yeah, send it to me by email. I'll open it from my side.
Okay, we have to do that. Okay, sorry.
Okay.
So I'm trying to do this now here. Putting. Okay, I'm sending it now. You can hear me? Yeah.
Oh, yes, I can hear you, but still waiting.
Yeah, it's
By
70%. It's almost WeTransfer. It's completed now. Have we got it?
Not yet, on the way. WeTransfer, is that right?
Yes, WeTransfer. Yes, yes.
Yes. It seems to be a big file, is that right?
Yeah, it's a big file. Yeah, yeah. Because it's a lot of photographs. Yeah, but there are no videos in it.
Yes.
So then I will just say next slide, and then you can just do from that. Yeah.
Oh, yes. It is downloading now.
Okay.
Just a matter of minutes. So how Sweden nowadays? Is it cold or is it?
So some parts we still have snow, and here in Gothenburg, it's the snow went away like a week ago. Yeah, but it's getting nice. What about in Riyadh? It's how
And Riyadh is okay, but we like this weather because it's not hot, not cold, so we like it really. In a few weeks we will move.
What's the temperature in Riyadh now then?
It is around 25.
Okay, that's good. That's like a Swedish summer, so that's nice. Yeah.
No, but you have to visit us in 2 months' time.
Then it's going to be 40.
Yes.
Okay.
Do you see my slides?
I see the slides. Yeah. So you can just make it. Yeah.
Okay. Go ahead, Doctor.
Okay. So I will present our experience in uterus transplantation, the Swedish experience, and also give an overview of the field. Next slide, please. So uterus transplantation is for those with absolute uterine factor infertility, and those are women born without a uterus or with no uterus after hysterectomy, as shown on the left side. And hysterectomy could be because of cervical cancer, leiomyoma, or peripartum bleeding. Or it could be women with a non-functioning uterus. They may have malformation, they may have intrauterine adhesions or radiation damage. And I have circled the MRKH or Rokitansky sign here, which is the most common diagnosis so far for uterus transplantation. Those are girls born without a uterus, but otherwise fully normally. It's also called an MRKH syndrome. It's 1 in 5,000 girls with that syndrome. Based on calculations from the UK on the prevalence and the number of inhabitants of Saudi Arabia, it should be about 5,000 women with absolute uterine factor infertility between the ages of 20 to 40. And of course, today in Saudi Arabia and also in Sweden, they have no chance to become biological mothers. And that is why uterus transplantation has been developed. Next slide. So I think you should be aware of that Saudi Arabia actually pioneered the field of uterus transplantation, because already in 2000, you did the first case ever of a human transplantation procedure. It was in Jeddah, and the group was led by Wafaq Fagir. The case was published 2 years later, and this is showing the publication. It was a partial surgical success because the graft survived for 3 months, but after that thrombosis and necrosis occurred, so they had to remove the uterus. But this case was very important for the global field of uterus transplantation because it's actually stimulated a lot of research in the field, and it also showed that it was surgically feasible. Next slide, please. So we started actually before the Saudi case. We started in 1999. We got an ID from a patient, and we started a translational research project, starting in the small rodents, mouse and rat, then to the pig and sheep, the large domestic species, and then to baboons. And then we started the first clinical trial in the world in 2012, and we got the first live births also in 2014. Next slide, please. And the reason why we did so much research for more than 10 years is that we had to perfect and optimize the procedure before human use. And these are some factors which you have to look at in animal models to get optimized conditions in the human. How would you detect rejection? What is suitable immunosuppression? And what about pregnancy and offspring? Is that affected at all? And also you have to have lively ethics debate. So we had several papers and several PhD theses on this topic in different animal models. I'll just show some examples of some studies. Next slide. So this just shows some papers, but we were able to do uterus transplantation in the sheep, and the sheep is a very good training model for the human because the size of the vessels and the uterus is about the same, but the surgery is a little easier than the human. So this shows that we got fertility in the auto-transplanted sheep model. Next slide, please. The last 5 years, we did a lot of research in baboons, non-human primates, which is as close as you can get to the human. And this shows one paper in human reproduction where we could try the live donor concept. We could see how long would it take to take it out from a live donor and to put it into a recipient, what immunosuppression should be used, and how could we detect rejection. And importantly, of course, a non-human primate would have very similar anatomy as a human, but of course with smaller structures. Next slide, please. So in 2012, we started with our first trial, which was the Sahlgrenska 1 donor trial, which was based on all this animal research. We did a case series of 9 live donor cases, and it was paid by the private research foundation, and that is important because in Sweden we have public health, and we could not let the public finance this, which were still in the experimental phase. Next slide. So the recipients we had were 8 with MRKH or Rokitansky. These were those born without a uterus, and we had 1 patient who had cervical cancer 7 years before the study. And they were 27 to 38 years, otherwise healthy, non-smokers, and low BMI. Next slide, please. So I emphasize this was a research study, and we had no guarantee that it would work. They would find their own donors, as you would do for a live kidney donation, and most found a suitable mother or other relatives, and in 2 cases it was not blood related, 1 mother-in-law and 1 family friend. But if you look at the ages of the donors and the recipient, you can see that donors were about 50 and some were up to 60 years of age, and we could also allow postmenopausal donors. And of course, importantly, the donor should have been through a normal pregnancy with delivery before, and they should also be with no other disease. Next slide, please. So the clinic flow would be that we would do screening and investigation, we would do uterus, and we would do IVF, so we would preserve embryos before, we would do uterus transplantation, we would wait for 1 year and start to get the pregnancy by embryo transfers, and then we would hope for pregnancy, and if they got pregnant, we would deliver by cesarean section. If they were happy with one child or medical condition would not allow any more children, they would do a cesarean section. Otherwise, we would go, would do a hysterectomy just after cesarean section. Otherwise, we would go for a new embryo transfer after 5 to 6 months and a second pregnancy. And of course, they would be immunosuppressed all this time. Next slide, please. So the donor surgery was not like a hysterectomy, because we needed large and long vascular pedicles. So if you see here on the red, you see that we took most of the anterior portion of the internal iliac artery on both sides, and we would take uterine veins down to and including segments of the internal iliac vein. And what is difficult here is mostly that you have to preserve the ureters, which are very close to the uterine arteries and to the cervix. Next slide, please. And the durations, it took us 3 hours to take it out in the baboon, but here actually to take it out in a live human donor, it took us 10 to 12 hours. So this was a very complicated surgery, but of course we had to be very careful not to get any injuries to the donors. Next slide, please. And then we would take the organ out and we would put this in the recipient as it is shown here, where we would put the long vascular segments end to side to the external iliac arteries and veins. Next slide. And I also want to say we do not transplant the fallopian tubes or the ovaries, only the uterus. And the time it took us to put it in, do the transplantation, was about 4 to 5 hours. And they didn't need any blood transfusion, no ICU, and the hospital stay was 4 to 9 days. The hospital stays for donors was 7 days. And this is important. These are two healthy, the donor and the recipient, two healthy persons coming in for surgery the day of surgery, and after surgery they're fairly well, and they don't need any intensive care. They can actually go to the ward and then they can go home fairly early afterwards. Next slide, please. So the 12 months results out of these 9 transplantations that were performed 2012, 2013 was that 7 out of those had a graft survival for 12 months. We had to remove 1, the number 9, after 5 days because of thrombosis, and number 2 after 3.5 months because of infection and hypoperfusion. And you see as number 5 here, some could have several rejection episodes, and number 4 had no rejection episodes at all. All the rejections episodes could successfully be treated and were diagnosed by cervical biopsies, as shown. Next slide. And of course, they have immunosuppression similar to kidney transplant patients. And here is the biopsies. In the middle, you can see there's a infiltration of immune cells. It's a low-grade rejection. We treat that by steroids, and 3 weeks later, it looks okay. Next slide. So the first live birth after uterus transplantation ever occurred in Sweden in September 2014 and was published in this paper in Lancet. Next slide, please. And this was our patient number 5. She was a 35 years old MRKH patient, and she received the uterus from a 61-year-old non-related friend. The surgery in the donor took about 7 hours, and in the recipient 5 hours. Next slide. And here the patient was fine, but in week 31 plus 5, she got preeclampsia, fairly severe preeclampsia, and we did a C-section in week 31 plus 6. And this is the uterus when we're doing the C-section. Next slide, please. And this is quite famous, this figure, this photograph is the baby's name, his name is Vincent, and he was the first uterus transplantation baby, and you can see the happy parents. Next slide. And here he's older, he's about 3 years, now he's 7.5 years in very good condition and has of course started school, and it's a very sportive, active little child. Next slide. So out of those, the first trial with 9 patients, we had 9 births. We had 6 patients getting a total of 9 babies. So 3 patients got to 2 babies, and they were all healthy and delivered normally. The only the only thing to react on was that we had a fairly high rate of preeclampsia. We had 3 out of 9 pregnancies with preeclampsia, and we think this is dependent on the single kidneys these patients had. Next slide. So if we sum up this, we see still the laparotomy the classical way. Out of the 7 patients with embryo transfer attempts, we had a 100% cumulative clinical pregnancy rate, and we had an 86% take-home baby rate, because one of these patients got pregnant several times, but only with miscarriages. And the clinical pregnancy rate per ET was 33%, and live birth rate per ET was 20%. So it's a little lower than in ordinary IVF. Next slide. So based on our study and so on, we and other groups started with the robotic uterus transplantation. And this, we were not the first one to do this. It was actually a group in China, and they did it already in 2016, 2 years after we published our first birth. And this is published in Fertility Sterility in 2016, and this is robotic surgery in the donor, in the live donor. Next slide, please. So we also started in 2017 with a robotic assisted uterus transplantation, but it was then only to do the donor hysterectomy by robotic. We did a step-by-step development, and we would have a maximum robotic time of 6 to 7 hours, and then we had to convert to laparotomy. Next slide, please. This just shows that we always studied the vessels very in detail before each case, because these are actually the critical point. So the results of this our robotic trial is published in 2 papers, the 6 months results, one in Fertility Sterility and one in Journal of Clinical Medicine, and I'll review the results. Next slide, please. So we had the Da Vinci XI with dual consoles. We had 2 robotic surgeons, and we had 1 laparoscopic surgeon, and this shows the placement of ports. And we have a gel port between the umbilicus and the symphysis in case we would get a venous injury, and with big bleeding, we could actually get in with the hand and stop the bleeding. And this was a safety measure. We never had to use it, but we had it and it was in our ethics protocol. Next slide, please. So we did a step-by-step robotic procedure, and we divided the steps into 9 different steps. Some were bilateral and some were only in the midline. And I will go through you here, but what it is aiming for is, of course, to get long vascular pedicles without injuring the ureter and the bladder, and dissect the uterus without attaching fallopian tube and the ovary. Next slide, please. So we start with the frontal dissection, and we divide around ligaments, and then we take an extensive bladder peritoneum because we need that for fixation in the recipient. And then we isolate the bladder from the cervix and upper vagina, as shown in one here. So this is a midline, and this is the classical thing you do when you do a hysterectomy also. Next slide, please. And then we do the crude dissection to identify the uterine artery and identify the umbilical artery, which we use as a point for grasping and for traction. And then we mobilize the anterior portion of the internal iliac artery so we can further dissect there. This is to see where is the uterine artery so we don't injure this. And you know, the uterine artery is one of the branch from the internal iliac artery. Next slide. And then we dissect the ureter. And then we do that, start at the bifurcation between the external and internal, and we dissect these towards the uterus, and we put rubber slings so we can move the ureter. That will aid in our dissection. Next slide. And then we do the ureteric tunnel, which is actually, this is the number 4, which is actually one of the most tricky parts. This is where the ureter is riding under the uterine artery and also where there are uterine veins. And this is a very firmly attached ureter to the vessels and to the cervix, and there are a lot of small vessels. And of course, you cannot injure the uterine artery as shown here also. And this is very good with the robotic approach because you can see really well and you can do very fine dissections. Next slide. And then we do the fine arterial dissection. That is to dissect the whole artery all the way up to the branching of the pudendal or to the gluteal artery, because we save one posterior branch. And then we have to ligate a lot of branches because we want the flow to go all out to the uterine artery. Next slide. And then we do the frontal ureter dissection, and this is also a tricky dissection. This is from the ureteric tunnel until the inlet to the bladder, and we have to mobilize the ureter. That is not the biggest problem. The biggest problem is to identify the uterine veins and not to injure those, because we need those in the specimen. Next slide. And then we do the fine dissection of the internal iliac vein and the branches of the uterine veins to get a full vascular tree of the uterine vein and a segment of the internal iliac vein, as well as the anterior branch of the artery and the uterine artery. And we use hemoclips, and we actually also secure those with sutures. Next one. And then we work on both sides. We do salpingectomy because we don't include the fallopian tubes, and we also divide the uterovarian ligament, so we don't include the ovary. And we also try to use this proximal part of the uterovarian veins as a possible way of later anastomosis if the uterine veins are of low quality. And this is of course done on both sides also. Next slide. And at last we dissect the pouch of Douglas, separate the rectum away, and we also divide the sacrouterine ligament. So these were all the steps, and that can be really well described in fertility sterility paper. Next slide. So if we look at our 8 cases, in the first case, we were not able to do so because we had in our ethics protocol, we had to convert to a laparotomy after 7 hours. We could not have them in the developer position for as long as we wanted. So in the first 5 patients, we were able to do more and more by robotics, and in the last 3 patients, we could do all the sub-steps by robotics. So this was a learning curve which took us about 8 cases. Next slide. So in the results of this recipients were that we did 7, but we actually had to do hysterectomy in 2 of those after 1 to 3 months because they had blood flow, but the blood flow in the uterus was too low and they would not develop an endometrium. They would get necrosis on the inner side of the uterus. But so we did hysterectomy, showed blood flow in the periphery of the uterus, but no rejection. So we had 6 out of 8 which were surgically successful. Next slide. And the first baby from this cohort was born in March 2019, and this just shows a photograph of that. And of course, there is also babies born from the Chinese publication, and also we have more in our Swedish trial. Next slide. So summary, we did 8, as I said, donor robotic assisted uterus transplantation, but we did all the recipient surgery by laparotomy. We had 6 out of 8 surgeries successful. So far, 3 of these 6 have delivered babies. We have ongoing pregnancies, and we have further embryo transfer attempts. And also, my prediction is that 5, hopefully 6 out of these will finally become mothers. Next slide. So in conclusion, what we have seen from our studies and from one study of 5 patients in the United States and from the Chinese case is that we can improve the dissection, we can decrease blood loss, hospital stay, and decrease sick leave by the robotic approach. But there is still no decreased surgical time. It still takes about 10 hours for the donor hysterectomy, and the problem may be the long position in the steep Trendelenburg position. Next slide. So we have started our 3rd study, which is a totally robotic uterus transplantation in live donor and recipient. So we got ethical permission, and we did first case in October 2021. This is not yet published, but the thing would be to do robotic surgery totally in the donor and also total robotic surgery in the recipient, just as they have started to do in kidney transplantation. Next slide. So this shows the port, and the donor is in the Trendelenburg position. Next slide. We use the Da Vinci Xi with dual console. We have side docking 45 degrees, so we can get access to the vagina. We then extract the uterus in a laparoscopic bag through the vagina. Very important here is the back table preparation to have very good vessels to suture, because the suture by the robotic surgery will take longer time than for open surgery. Next slide. And this is the recipient, and this shows that we put a gel port above the pubis, below the umbilicals, and the placement of the robotic and laparoscopic ports. Next slide. And here we actually place the uterus. We don't take it in through the vagina. Put that inside with a small hand through the gel port, shown here. Next slide. And now the uterus is placed in the abdomen, and you see here that we also have a tubing, and that is to continuously flush cold preservation solution. And then we take the gel port away. Next slide. So we take the gel, no, go back one. Yeah, so we take the gel port away, we close that when the uterus is inside. The transplant surgeon do the fore-anastomosis on the external iliac artery and vein, uses Gore-Tex sutures. We then open the vagina, we do the end-to-end anastomosis to the vagina and to the uterus, and then we do fixation, and then we stop. And the procedure in the donor took about 10 hours, and the procedure in the recipient took about 6 hours. Next slide. So this is, to our knowledge, in the first in the world, totally robotic uterus transplantation was done in October 2021. The patient is doing fine. Menstruation started from 1.5 months after transplantation. She had no rejection. And we will start embryo transfer in August. That is 10 months after uterus transplantation. Next slide. So so there are about 90 procedures performed, most live donor procedures, most by laparotomy, and those have now produced more than 40 babies. We have 15 in Sweden, and we have also been helping babies transplantation procedures in other countries such as Germany and in USA and in France. So this is a procedure which is coming. Next slide. Yeah. So my conclusions are that uterus transplantation is the first treatment for absolute uterine factor infertility. It is in a transition from experimental to clinical procedure in many countries, including Sweden. And I think that robotic assisted uterus transplantation will be the main method in live donor transplantation, and this will be both for the donor hysterectomy and for the recipient. And my hope is that we can help to assist in the introduction of robotic uterus transplantation in Saudi Arabia. We have been discussing with Saudi Arabian doctors for many years about this possibility, and we hope this can be a future. Next slide. And this is the last slide. I just want to emphasize this is a team effort. This shows the team who did transplantations in the sheep, the ones in the baboon, and the humans. It's about around the same people, and it's not only gynecologists, it's transplant surgeons, anesthesiologists, nurses, pathologists, and so on. There's an International Society of Uterus Transplantation. The webpage is shown here if you're interested for more information. We have yearly meetings, and the next meeting will be a webinar meeting in October 2022. And importantly, we have also started an international uterus transplantation registry. Thank you very much for your attention, and I'm sorry for the delay because of the problem with sharing the PowerPoint. Thank you.
It is really impressive that we have this transplant for uterus. I thought it was a dream, but it seems to be now it's not a dream, it's a fact.
No, so, now it's a reality. Yes, yes.
Yeah, it is impressive, really. Well, I believe this is a good news for a lot of patients that will suffer from infertility, and of course there is a hope in the future. The medical field is progressing, and but I think I missed one of your slides. Those patients who get a transplant, I think they will be on immunosuppression for some time. Is that right?
Yeah, I didn't take that, but the immunosuppression is, of course, I said that it was the same as a kidney transplantation. We used tacrolimus and azathioprine, so there will be that on that all the time they have the transplant, which will be about 5 to 7 years. Yeah.
And this, of course, will be okay during pregnancy. Is that right?
Yeah. So the immunosuppression is a little nephrotoxic, but usually it comes after many more years. Yeah. So there are no big side effects, and the advantage is that, of course, that you have this only for a restricted time, for 5 years, 5 to 7 years, and then you can get 1 or 2 up to 3 babies. Yeah.
So if they are going to get pregnant, it should be in the first 5 years. Is that right?
Yeah, they should try to get pregnant after 10 months, and they should try, and if they want a second or third pregnancy, they should try for that fairly soon after the first delivery. Yeah. Because we want to minimize the time where they are on immunosuppression, because then we do little less harm to the kidneys.
I see. Well, thank you very much. I will introduce your parts to my colleagues in gynecology. I think they will be interested in that. Your idea is brilliant. I never cross uterus transplant in Saudi. I never heard of that, but I think we'll discuss this. Of course, your experience is unique, and I'm sure my colleagues will be interested. I'll connect you with them later on. Thank you very much, Dr. Mas.
Thank you very much. Bye.
Bye. Our next speaker, Dr. Somash, how are you?
I'm fine, thank you, thank you. Nice e-meeting, all of you.
Thank you very much. Let me introduce you, just allow me for 1 second. Yes, Professor Somash, he is a chairman of oncology, Manipal Center, Cancer Center. He is the head of Department of Surgical and Gynecology and Oncology and Manipal Comprehensive Cancer Center, Manipal University in Bangalore in India. Dr. Somash is well known and he's a famous and he get the Gujarat University Gold Medal and Record holder. He's the president of ABSI, Association of Breast Surgeons of India. He's editor-in-chief and Springer India Journal of Gynecology and editor analyst of Breast Disease Journal. He's the council member of ISSPP and IGOI, the founder member of CRSA, a Clinical Robotic Surgeon Association in India. It is a privilege having you with us, Dr. Somash, and I'm really happy that we have an expert person like you. Thank you very much. Please proceed.
Thank you very much. It's my pleasure. I wish had it not been for COVID pandemic, wish you could have all come down to India. I do about 60 to 70 robotic skill course and mentoring of various colorectal, then esophageal, gastric, gynecological oncology, thyroid course every year. And we travel across the world because my program is about 12-year duration, and I've done over 3,000 complex robotic cancer procedures. So I wish this COVID was not there. You could have come and probably I could have come there. So I bring warm regards from India and my center. In the next few minutes, I'm going to touch upon the various recent advances that happened in the history of surgical robot and its relevance to surgical oncology. And since I am a surgical oncologist, we do all cancers in India, you know that. We do large amount of GI surgeries, hepatobiliary, gastric, upper GI, thoracic, and gynec-onco. So we all knew that in oncology, we thought open surgery, the bigger surgery, big incision, big surgeon. The oncology community took a lot of time to adapt minimal access surgery because we thought cancer disease is such a dreaded disease. If there is a margin of error in minimal access and robotic, it's very tough. So that's one of the reasons that it took very long time. But a paradigm shift happened from open to lab and then to robotics. This is my favorite slide. I call this surgical excellency pathway. Any resident or any surgical colleague who want to take this path should believe in revolution, not just evolution, to be at the tip of the pyramid of mastery of surgery, and we need to do that. To do that, we need an equipment which has zero margin of error. There are two other fields in human mankind where margin of error should be zero. One is when you handle in atomic radioactive substance, you need to have a zero error, so you have a robotic arms. Second is the space technology, where human beings go to space, moon, and satellites, where margin of error should be zero. And the third one is surgery. So the surgical robot performs 1,600 error check every second in each arm to give a flawless, safest surgery possible to the human beings. And it is coupled with 3D image, endorist, dual console, and various factors. And to do a robotic surgery, you don't have to be in the same country or the hospital. We all know that the first robotic surgery was done, surgeon sitting in New York, and the patient was in France. So with a 5G technology, you can actually go ahead and do. What are the advantage of robotic surgery over the laparoscopy? It has got a short learning curve. There are no counterintuitive movement. Vision is hugely magnified with stereoscopic 3D with 12x magnification. Very stable platform. It is told that a senior surgeon who has a good brain and experience, but he still develops a Parkinsonism, he can actually sit on robot and the tremors are cancelled. Very precise dissection possible, forearms available, laser, vessel sealer, all available. Even in the non-dominant left hand, if you are a right hand, you can perform a beautiful suturing, less complication, less blood loss, and painless surgeries you can do. And there is a very less fatigue, not to say patient, surgeon sits and operates. When there was a minimal access surgery, this is the data from USA. Unfortunately, the penetration in GI surgery is less than 60%, and gynec was 30, and uro and cardiac was even less. That shows that in complex procedures, laparoscopy falls short because of these disadvantages: steep learning curve, limited dexterity, counterintuitive movements, 2D image, no depth perception, ergonomically tough. This is not about doing a simple procedure, but a very complex surgical oncology, cancer surgeries. That is where the robotic actually comes, and not limited by the surgeon's experience. You have 7 range of movements, and you can see that each instrument actually tip is 3 millimeter, and you have an endorist technology to do this particular surgery. And the advantage is there is cancellation of tremors, filtration, microanastomosis, motion scaling, telesurgery is possible. Like for example, in Bangalore, in India, the robotic program of cardiac surgery, you do a coronary bypass. Instead of a sternotomy, putting the patient on heart-lung machine, keeping them in ICU, blood transfusion, heparin, you can do a robotic coronary or heart surgery, and then the patient can be discharged with just 8 millimeter 3 punches in the chest and a beautiful suturing of the vessels, and average time of discharge is 16 to 18 hours without blood transfusion and need for ventilator or pain or ICU admission. Like for example, this is a video. You can see that with the robot, that one arm is going to stabilize the organ. The other 2 arms are going to peel the grape leaf without touching the pulp with huge magnification. That is how the stability of the robot. How do you transform this particular thing? This is me doing a lateral lymph node dissection in the pelvis. You can see I'm working between the psoas major muscle, external iliac artery and vein. In laparoscopy and open, you normally put a vessel loop and hope the assistant retracts the vessel and doesn't leave. But in robotic, here comes my best resident. That is the third arm of the robot. It would go down and it uses like a vascular retractor. It will adjust the tension on the vessels, and it is go and make it perpendicular with endorist, and it will hold that vessel in that place without moving a millimeter. I can go down to the obturator fossa and do the necessary surgery, even in the lateral lymph node dissection, rectal cancer, and pelvic lymph node dissection, gynecological oncology. This is a case where I'm doing a robotic right hepatectomy. We know that the whole liver surgery is nothing but working around the small blood vessels that is coming from the vena cava directly into the caudate lobe. You can see the third arm of robot is stabilizing the liver. My arm 1 and arm 2 goes and removes the liver, and then I can suture the edges. So you can retrieve the whole specimen with a small suprapubic incision, and patient can have food same day possible. And this is a case where robotic Whipples I'm doing and forming a tunnel between the portal vein and then the superior mesenteric vein is extremely easy for us. And the beauty of the robot is this is a case of gastric cancer where I'm doing a D2 lymph node dissection. We all know that the lymphadenectomy is nothing but playing on the vessels. This is a hepatic artery. You can see how stable the robot is. Third arm is lifting the liver, arm 1 and arm 2 with a robotic hook with the endorist. I'm going to navigate on station 10, 11, 9, and 8. And then I cut the superior border of the pancreas capsule. And once I cut this particular area, the entire vessels actually come to my area and we can expose them and go ahead. Look at the stability, magnification. The camera has 2 telescopes and there will be no fogging of the camera. And you can play around this entire vessel system very comfortably. And this is the splenic vein, which I'm taking from the celiac trunk. And due to its stability, I can easily handle this. And lymphadenectomy is a boon in case of robotics. And most of these patients would just go and walk on the same day with the ERAS protocol and robotic surgery. So what I found in my last over 3,000 complex robotic surgical oncology procedure is they have got the lowest conversion rate. If you look at the robotic colorectal, even in the best institution, there is about 7 to 11% conversion rate. And sometimes it is as high as 20 to 25% in learning curve. But with robotic, you have less than 1% conversion rate, even in the complex surgery. These are the studies which showed that when you compare open surgery, laparoscopic, and robotic, robotic has the shortest learning curve, followed by the open and the last by laparoscopy. About 8 years into my program, now it is about 12 years into my program, when I completed 1,600 robotic surgery, I plotted my learning curve, which I published. All it took was 15 complex surgery for me, my team, my sister, my technician, to bring down the duration of surgery to under 200 minutes and to complete that with less than 1% conversion. I will give an example. This is a young male who has got a tumor in the thoracic inlet on the right of the trachea. And you can see that traditionally, if you do a thoracotomy, this patient would stay for weeks and then he would need a rehabilitation of about 2 to 3 months. Here you can see that there's azygous vein, the superior vena cava, and the phrenic and the lung. The beauty of the robot is, look at this arm one, how it can turn back like a swan neck, and you can dissect the pericardium and supply this tumor. And this person got surgery done in the morning and afternoon, he had a meal, and next day he was ready to go home with very minimal pain with just 8mm punctures. Another beauty of the robotic over laparoscopy is beautiful suturing. You can sit on a robot on a day one. You didn't have to be a laparoscopic surgeon ever. Still, you can do a beautiful micro suturing with left hand and right hand with 6-0 Prolene or monocryl. And I'll show you, these suturings are not simple suturings. You know, the most important thing is, you can see that this is a case where I'm completing a total mesorectal excision. Typically, when you do a laparoscopy, you would use about 6 staplers to do this: proximal dissection, distal dissection. You do a small wound port and mini laparotomy to retrieve specimen. The way I would do is, I would just tie an umbilical tape and transect this. And you can see that I would give an ICG and look at Firefly where proximally in the descending colon I can transect. I go ahead and I transect with cold knife. And once I do that, I put the whole specimen in the bag. And once I do it in the bag, I throw a beautiful robotic hands purse string. So, I throw a beautiful proximal purse string and distal purse string, and then the whole specimen in an ultra low LAR sphincter preservation. I would pass the robotic anvil through the transanal route through the natural orifice surgery. And then I would tighten the purse string because we have EndoWrist technology, and I have an ICG Firefly, and then a swab and holder comes down and the entire specimen would be retrieved transanally. And you can see that the whole pelvis, the pelvic diaphragm, pubococcygeus and levatrinae muscles and the puborectalis sling is intact. The beauty of robot is I can go to the intersphincteric area and I can put this fantastic purse string on the puborectalis sling left over anal canal. And once we do this, I would restore the anastomosis. So you can see that hands-on anastomosis was done, only one circular stapler, no mini laparotomy or incisions on the abdomen. And then I would do a leak test. And since the vascularity, no tension, hands-on anastomosis is there, we would not do a stoma. So this is beauty of this. And then another thing is we have a third arm of the robot, which would hold at a 90 degree. So I can work around the vessels. I am a inferior mesenteric artery, inferior mesenteric vein. I can go down, I can work around, and I can take them beautifully. This is something which lacks in laparoscopy. The third arm of the robot is my best arm. It gives a beautiful traction, counter traction. Look at this, it holds the parietal layer and visceral layer, VLPF, PLPF, and the whole space of yield. We can go around and I can work around with EndoWrist with sharp dissection, no harmonic, no ligature, sharp dissection. I can identify all the nerves, sympathetic, parasympathetic. We can work around, not just do TME, but we also do CME, complete mesocolic excision. I can turn back, go on the other end of the vessel, and I can come down here. The tip of the vessel is 3 millimeters. So without a rent in the mesocolon and the mesorectum, we can do not just a TME, Japanese D3 radical colectomy too, and I can separate all the branches of the artery and IMV, and I can individually take them, and you can see that the entire nerve preservation happens. This is beautifully possible. And look at the way the robotic hot shears can turn to the pelvic wall. Not only superior hypogastric plexus, but inferior hypogastric plexus, nervii can be done, and you can work laterally with a fine tip dissection, which is a beautiful hallmark which is possible in this. This is a case where I'm doing a robotic Whipple's for pancreatic cancer. The most difficult step is undilated pancreatic duct, 2 to 3 millimeter pancreatic duct. I'm doing microneedle anastomosis with the robot. The most tough procedure becomes the most pleasurable, easy procedure with 6-0 PDS. And this is the beauty of suturing in the robot. When I say suturing is easy, it is the complex suture. This is a case I'm doing esophagus in the thorax. You can see I'm taking a purse string on the thoracic duct, which is between the aorta and then the azygos vein. You can see in that narrow window between the azygos, aorta, behind the body of vertebra, you have to go locate this thoracic duct and take. These are the complex suturings, which are a pleasure for us to do. You don't have to use many staplers, you don't have to use clips. You can use suturing to ligate the azygos veins and other part. Also, when you do Ivor-Lewis for GE junction, nowadays adenocarcinoma of gastroesophageal junction is very high. I do a Ivor-Lewis and an anastomosis in the right thorax. I can do the entire anastomosis of the esophagus and gastric with the robot. The other advantage is the nerve preservation. Because of bloodless sharp dissection and huge magnification, the inferior hypogastric plexus and the other nerves can be beautifully seen. And we did a randomized control trial where we do a sphincter preserving ultra low LAR. Same day we remove the Foley's catheter, and then we shift the patient for urodynamic study and post-residual urine ultrasound. When I compared my result with classic trial published in British Journal of Surgery, you can see that 22% becomes 4%, and the sexual function is very good. This is one of the large study, one of the few randomized control trials in robotic done by me way back about 8 years. And also I published in Journal of Minimal Access. You can go and read the advantages and tips and tricks. This is a study I performed at my cancer center, open laparoscopic and robotic rectal cancer. The lymph node yield was highest, conversion was less than 1%, CRM, circumferential resection margin was negative, more in robotic, and then the distal margin was highest. Also, if you have a head and neck cancers program, you don't have to do a lip split, mandibular cut, feeding tubes, tracheostomy. You can see that this is a robotic TORS program, transoral robotic. You can see on the left-hand side, I'm sitting there, it is me sitting there, and the robot is docked into the mouth. If you have a luminous CO2 laser in your institution, it can be integrated into robot. This is the recent advances in the robot. Luminous laser can be integrated. There is a laser drop instrument which you have in robot. You can go through this, you can excise it in a bloodless field with a negative 1 centimeter margin. And then the beauty of these procedures in oncology is there will be no scar, no tube, and daycare discharge. I get a lot of women from UAE and others for thyroid who don't want a scar in the neck. So I do gasless, scarless, transaxillary surgery where we use the robotic instrument, and I go and retrieve and do a neck dissection and central compartment. You can see this is the recurrent now. I'm handling very delicate because of the robotic traction which I give. I don't take the assistant's help in this, and then we can do a beautiful radical dissection. And this is the parathyroid which is falling down. And we have done the largest series of robotic in India, and no scar and daycare discharge without tube. I have published in Journal of Minimal Access tips and tricks how to perform a scarless. You can go back and read very large number, more than 150 scarless thyroidectomy I have done, and I have discussed about it. We have a very large gynae onco program. You know that in India, very large volume of endometrial, CA, and cervical cancers are there. So we do this. The beautiful surgery in the pelvis is a fantastic lymph node dissection you can do. And what I would normally do is I go behind the vessels, down onto the iliolumbar trunk of the sciatic nerve. And then I would not only preserve the obturator nerve, but I would go down and dissect this. And then the whole anatomy after robotic dissection looks like a textbook anatomy, what you would see in a Cunningham. All the branches of the internal iliac, superior gluteal artery, accessory obturator, the obturator, now the femoral canal. You can see that the clocket node is removed, and this is the femoral canal. which is down there in the posterior pubic ramus. And this is the obturator now. And this is the iliolumbar trunk of sciatic now. And these are all daycare surgery I perform. We admit in the morning, I do in the afternoon. ERAS protocol, no Rice tube, no Foley's catheter, and I would discharge evening with the meals for a patient with a shower. At the end of the day, they can go. The second advantage is if we have testicular malignancy and then gyne-onco malignancy, reaching up to the renal vein is important. We call that high para-aortic. This is a randomized controlled trial I foresaw and I published, where we developed a technique. You can go up to the transpyloric plane, up to the duodenum, and what I popularized as a midline split lateral roll technique, we do a high para-aortic lymph node dissection with the robot. These are all daycare procedures, no clips and no harmonic, no ligature, purely monopolar and bipolar dissection. And this is a large work I published on a learning curve, how to do a high retroperitoneal lymph node dissection and the techniques. You can go back and read in the robotic surgery journal. So when I looked at my Kusum curve, it is all 12 cases that you took. You don't have to be a laparoscopic surgeon, good open surgeon, GI surgeon, urology surgeon, surgical oncologist, and then gyne-onco. It would take about 12 days for you to go ahead and do. We have over 62 publications in this surgeries. You can also visit my YouTube and various techniques I've put there. This is a supra-azygous recurrent chain of lymph node dissection, which I show, which is very easy for you to do. And this is the publication. You can see the Firefly ICG of the robot, how it shows the entire thoracic duct, which is seen in the thorax, how the thoracic duct is seen by Firefly, and which becomes very easy. The other beauty of robot is you can sit in Saudi and sitting in India. I have a remote training access program and a software. I can train you by remote case observation. You can sit in Saudi and you can go back and then learn this. And the other advantage is when you use an ICG Firefly, you can do a beautiful sentinel lymph node technique, which I'm showing here. So which is inbuilt in case of robotics. And in colorectal protocol, when you do a complete surgery, you can know where to place an anastomosis. If you give ICG IV, it shows where it stops. So that's why less leak anastomosis, no splenic fracture mobilization required if you use ICG. This is one of the first publications which I did in Journal of Robotic Surgery, JRS, the most prestigious. You can go back and read. So these are the advantages which you have: liver surgeries, pancreatic surgery, colorectal, and head and neck. We also have an ultrasound which is integrated in the robot, which surgeon can sit and see through that. So you can do an intraoperative ultrasound. The recent advances is the robotic stapler. The beauty of the robotic stapler is, unlike the conventional robot, it has 120-degree cone movement. You go down and do this. You can see it is an ultra low LIR I have done. And one sure form stapler technique, it can transect off the whole procedure. So this is something which you can take a perpendicular 90-degree, 120-degree cone view, and you can do. This is a total gastrectomy I'm doing, and I can go down to the esophagus and I can transect this whole layer and do a hand suturing, which is most important. Now we have to conclude in last few seconds. Now the new robot that has come is called as Robot SP. It is a single port through the umbilicus. We go through this particular robot. Even the camera is endoris. So there is only 25 millimeter single port through the umbilicus. The camera opens up, all the instruments open. You go and do radical prostatectomies, colectomies, and then ultra low LIR, and then you come out, and that is all that is available. And the new robots are coming with microscope intraoperative, so you can know where the margin is. So to conclude, it is not just beneficial to the patient, but also to the surgeon. Occupation hazard by the surgeon, neck problem, shoulder problem is not there, and then it adds new lease to the patient. Thank you very much. I would welcome everybody to India. You're most welcome to come down to my institution. We do about 500 complex robotic surgical onco procedures a year. We train about 100 robotic surgeons, various surgeons over a year. I train and I travel across the world for mentoring them. You're most welcome to visit my center. It would be my pleasure. Thank you, Professor Mohammed Al-Harbi, for inviting me. It's my pleasure to be with all of you. Thank you.
It is really impressive, Dr. Somash, and to be honest, being available with us, this is, make our event impressive and beneficial. This year, unfortunately, wasn't as strong as the last year, but next year, to be honest, it was my fault because we have short preparation. I have short preparation, but hopefully next year we'll invite international big names from Europe, and of course you will be joining us. Being such societies and training center, this of course will make our meeting more beneficial. More attendance will come to listen to known figures like you. And I was really astonished about the last single port robotoscope that you showed. I compared that to the single port laparoscopy, but I believe it doesn't have the same issue because the single port laparoscopy, the scope is giving narrow angle and you cannot have the safety margin of dissection. But I believe this is not the case in robotic. Is that right?
Absolutely, because the range of movement of instrument is endorist. So you can move a wide range, and even the camera tip is endorist. So you can turn left, turn right, you can have a full panoramic view. So you are not limited by a laparoscopic cramped area, and you are not unsafe. Once you put it, it just looks like any other robotic surgery. We don't get cramped there.
Well, yesterday, one of the speakers, he's from India, he spoke about that we can utilize robotic for a specific purpose due to cost issues. So you should not make the full payment or the full purchase for the full set of the bin sheet. You may utilize limited specification to reduce the cost. But I believe the robotic is becoming like a movie. It's every time there is something new. So I think they understand our psychology, going more and more for precise surgery. It is quite obvious that the precise dissection, either sharp or low, and the learning curve, which is shorter compared to the laparoscopy.
Absolutely, you're right. It's absolutely right. You're right. So what I do in my center is I apply ERAS protocol along with them and try to do a day case surgery. And in case of robotic, I don't use harmonic ligatures. So everything is monopolar. So I save a cost of this vessel sealer, which is mandatory in laparoscopy. And you can do a lot of hands-on anastomosis. So you save the cost on the stapler. And we try to discharge them as a daycare. So it becomes more cost viable than the laparoscopic program.
I'm sorry, I think my internet is
Yeah.
just disconnected. Thank you very much.
Thank you.
And I'm really pleased being with us. I'll be in touch with you maybe in the coming few days, because I'm really interested about your activities, and you have extensive experience. Thank you very much, Doctor.
Thank you very much.
Thank you. I think our next speaker is Dr. Dr. Sanjay Parkash. Dr. Mario. Dr. Mario Moreno.
Yes,
Oh, Dr. Moreno, how are you?
I'm fine. Hi.
I'm really sorry. I'm really sorry to call you on the weekend, but I couldn't imagine that that will disturb your time. I'm really sorry, but thank you very much being with us today. And you are welcome. Let me introduce you, please.
Oh, it's a pleasure for me, but I'm not Professor Marino because Professor Marino is not able to attend the meeting today. My name is Simone Rolfo. I'm one of his co-workers, and I will be in favor of Professor Marino.
Thank you very much. Please proceed, Doctor. Thank you very much.
Thank you. Okay, so okay. Can you see my slides?
Yes, Doctor, we can.
Okay, so many thanks to the Congress, to you for your kind invitation, and apologies from Professor Moreno, but can be here. My name is Simone Rolfo. I am associate professor at the Department of Surgery of the University of Torino, Italy, and my talk is about robotic redo bariatric surgery. So the number of bariatric procedures are growing up, and this is the data from the ASBS database, and as you can see, in 2019, the bariatric procedures were more than 250,000 procedures. So usually, a bariatric procedure never requires reoperation, but there are a lot of cases, about 7 to 15% of the total number, that require a revisional procedure. Revisional procedure is usually divided into revisional, when the anatomy of the initial procedure is preserved. For example, reshaping of the gastric pouch in a gastric bypass, or elongation of the biliary or the alimentary limb. A conversion procedure, when the anatomy of a different bariatric procedure is created. For example, a conversion from a vertical bending gastroplasty to a gastric bypass. This is probably the most common situation. And the last one is the reversal, when the original anatomy is restored. Reversal of a gastric bypass is a possibility, for example, for uncontrollable hypoglycemia after a Rowan-Ipsilon gastric bypass. And probably the rate of reoperation after bariatric surgery is even higher. These are the data from the Swedish SUS study registry with a follow-up of 26 years. And in this paper, there is a 28% rate of revisional bariatric surgery. Most of cases were vertical bended gastroplasty, but there are a lot of cases of gastric bypass and gastric bending. And in this paper, most common indication to revisional surgery were complications, stenosis, dilation, pouch enlargement, nausea or reflux esophagitis, or weight-associated complications, so weight regain for the most common situation. And of course, revisional surgery is more challenging than primary bariatric surgery. As you can see in this paper, the rate of total morbidity is quite the double in revisional procedures, 6.5 versus 10.3%. And this is mainly due to a difficult operatory field with a lot of adhesions, modified tissue planes with a modified anatomy, and the decreased vascularization of the structures that we have to dissect. So the technical advantages of the robot in this particular situation is due to the three-dimensional high definition visualization, tremor filtration, direct camera control by the surgeon. Of course, the instruments are raised and suturing making easier the suture, and robotic arms help to compensate the weight of the abdominal wall. This is a quite common problem in super obese patients, and is very heavy for the surgeon, and so the use of the robot is more comfortable and usually avoids instrument bending or breaking. This is a short demonstration of a case of a conversion surgery from a vertical bending gastroplasty to a gastric bypass. The most common problem is the dilation of the gastric pouch in this type of patient with a severe dysphagia or reflux esophagitis, and this was the case. This is the patient that made a open vertical bending gastroplasty more than 10 years before, and had an uncontrollable dysphagia and a severe esophagitis. This is the barium swallow, and you can see here the dilated pouch. This is the setting of the trocar. These are the 4 robotic trocars, one more for liver retraction and one more for the assistant. And this is the setting of the robot in the OR. So as you can see, there are a lot of adhesion between the pseudopylorus and the left lobe of the liver. This is the beginning of the procedure to expose.
I think that you are stopped at slide number 4, by the way.
What?
We see only slide number 4. We see no video.
Oh. You can see now something?
No, only slide number 4.
Okay, so I try to open the video from another directly. Can you see the video now?
Oh, yes, go ahead.
Okay. So these are the trocar, 4 trocars for the robot, one more for the liver, and one more for the assistant. And this is the setting of the robot in the OR with the XI, Da Vinci XI. So as you can see, there are a lot of adhesions between the left lobe of the liver and the pseudopylorus. You can see here the wires of the previous operation. And this is a very challenging phase because it is not easy to find the right plane between the liver and the stomach, because you're not to have so much bleeding from the liver and you're not to injure the tissues that you have to use to perform the gastric bypass. So the robot is very gentle in making this type of dissection. It's very accurate, and you can easily control bleeding from the liver, avoiding to damage the stomach. And you can see here complete separation of the proline of the previous operation from the liver. And this is another difficult step. It is the division of the gastric pouch from the fundus of the stomach. It was a vertical banded McLean gastroplasty, and these are the adhesions between the gastric pouch and the fundus of the stomach. This is a very, very difficult phase, and it is very dangerous because it's easy to make a hole in the stomach. And this is the phase which we have to perform the retrogastric tunnel just above the pseudopylorus. And it's very easy to make this phase with the robot because of the possibility to control very well hemostasis and to have a good angle. This is the last adhesions between the pouch and the fundus. And this is the tunnel where we can pass through and cut the stomach with a stapler. Then we can pull up the bowel loop. We usually measure 100 centimeters from the angle of trites. You can fix the loop to the gastric pouch. It's very easy to do, to suture with your robotic arms, of course. And then we perform the first posterior layer. Continue suture. Then we open the stomach and perform the second posterior layer. This is a very difficult suture to do with laparoscopic instrument, and the robot make it very, very easier, very accurate and easier. This is the completed suture. This is the second anterior layer. And in our technique, we do not divide the mesentery here in order to avoid internal hernias. That is one of the most common complications. We directly divide the loop here. This is also called the double loop technique. Just next to the GJ anastomosis, leaving intact the mesentery. And then we measure 125 centimeters and fix fix the loop and make the JJ anastomosis. Okay, so we can come back to the slides. Okay, can you see my slides?
Yes, number 9.
Yes. Okay, so this is our experience in the revisional robotic bariatric surgery, and we have 43 cases of vertical banded gastroplasty, conversion to ranipsinal gastric bypass, 15 sleeve gastrectomies, and 10 vertical adjustable gastric banding. The main indication, you can see here the main indications that were persistent dysphagia, gastroesophageal reflux, weight regain, or insufficient weight loss. And these are the baseline characteristics. And you can see the mean BMI was 35.8, not so higher because there are a lot of cases of dysphagia and GER with a very low BMI. And one of the major concerns about robotic surgery are costs, of course. And this is a cost analysis in our experience. So as you can see, there are a lot of costs for surgical tools and a lot of costs for robotic maintenance. And you can see in this chart.
Next slide, please. This is slide number 9. Can you go to the next? Is this the cost slide?
Yes.
Number 9.
Number 9. So I don't know why the slides.
It seems to be not moving.
No, they are moving on my screen, but not on your screen. So okay, this is slide number 10. Cost. Yes. Okay. So there are a lot of costs for surgical tools and a lot of costs for robotic maintenance. And as you can see in this chart, there are many costs for the operating room and many costs for the robotic tools and robotic maintenance. Of course, robotic maintenance depends on case load of the machine. We have a high case load, but even if you have a high case load, robotic maintenance costs are even higher. So mean total costs for patient without complication are about 14,000 euros or $60,000. There is a very high cost. And the question is if these costs are justified by the literature, by the evidence that you can see in literature. Can you see the next slide or not?
No, not moving. I think you have to double click the left panel.
No, it doesn't work. I'm sorry.
That's okay. Go ahead.
So what we can see from literature is that the robotic and laparoscopic approaches to at least to Roux-en-Y gastric bypass are similar, with the robotic approach taking longer and costing more. There are recent data from the MBSA QIP database that shows for the robotic arm increased operative time and increased length of stay. But of course, the level of evidence is very low because these are all retrospective comparative studies. So there's need of a randomized control trial with a level of evidence quite higher to see that robot is only more expensive and it's not so useful compared to laparoscopic surgery. I would like to show you this slide. So this one, can you see the slide?
Yes.
Yes. And this is a recent systematic review and meta-analysis on periterative outcomes, including 6 comparatively retrospective studies comparing robotic versus laparoscopic revisional bariatric surgery. And as you can see, there are no differences in early postoperative complications, and there are no differences in conversion to open surgery, reoperations, or readmissions, and no significant differences in operative time and length of hospital stay. So the conclusion of this work is that despite limitations, the systematic literature review showed no significant advantage of robotic-assisted revisional bariatric surgery, and on the other hand, a non-inferior efficacy compared to standard laparoscopy. But of course, further high-quality studies are needed to address these issues. So I think that at the moment, we can only conclude that robotic-assisted revisional bariatric surgery is safe and effective after an unsuccessful bariatric procedure. Outcomes are surely comparable to laparoscopy, but a definite conclusion is not possible without a randomized trial. Operative outcomes are acceptable with low rates of adverse events and conversion to open procedure. So, of course, the robot is more comfortable for surgeons. It's easy to suture, and you can do difficult movements with make difficult movements very easy. But we have no demonstration in literature that the costs derived from the robotic use are justified by better outcomes or better results compared to laparoscopic surgery. Thank you very much for your attention.
Thank you very much, Doctor. It's really an interesting talk. But I guess, technically speaking, robotic for revision of bariatric surgery would be more practical and more easier to avoid further complication or injury in comparison to laparoscopy. It is strange that in your study that it didn't show a statistical significance difference. Is that right?
Yes, it is right. There are no studies in literature showing a significant difference between robotic and laparoscopy. And I agree with you, this is strange. But actually, we have no demonstration that robot is better than laparoscopy in literature, unfortunately. And it's quite difficult to design a randomized control trial because the advantages of the robot are so evident that it is difficult from an ethical point of view to randomize the laparoscopic procedure to a robotic procedure. So in my experience, I would like to use always the robot for revisional surgery, of course. This is not the same for primary bariatric surgery. I think that in primary bariatric surgery, the robot is not so important, but in revisional surgery, yes.
Do you think that the cost is justified by your study, that there is no much difference in complication or in but do you think that the cost, I think the cost is maybe double or triple the cost of laparoscopy? Do you think it is do you suggest that not doing robotic for revision because of it is almost the same result and the cost is higher, or do you have a further opinion?
I think that for very challenging procedure, we can accept double costs or triple costs if we reduce the complication rate. But of course, to learn to use the robot for a very challenging procedure, you have to use it for more easier procedure in order to have your learning curve. So this is a very complex dilemma for economic aspect and the technical and practical aspect. So it is difficult to show to our administrators that there are incredible advantages from a technical point of view in lowering the complication rate. But we know we have no practical demonstration, and we have to pay great attention to costs in our daily practice, of course, in every country. So I think that the only way to reduce significantly costs is to reduce to improve the case load, to use the robot as much as possible in order to reduce maintenance cost and fix maintenance cost. And probably this could be an option, but it's very, very difficult to show from a randomized study the real advantage of the robots.
Yeah, well, thank you very much, Dr. It's really very impressive to have your presentation, and please send our regards to Dr. Moreno. Maybe next year, both of you will share with us our meeting.
Yes.
And thank you very much.
Thank you too. Thank you.
Thank you. Ciao, ciao. We will move now to our next speaker, Dr. Sanjay Prakash. Dr. Sanjay.
Good evening, sir. Are you able to hear me?
Oh, yes, Dr. Sanjay. How are you?
Doing good, sir. Thank you.
Nice to meet you. Dr. Sanjay, he's a urologist, andrologist, a reconstructive robotic surgeon, laparoscopic surgeon. He's working in genitourinary surgery, renal transplant, Apollo Main Hospital in Tamil, India. He's a consultant urologist. Thank you very much, Dr. Sanjay. It's really a pleasure having with us today. So please proceed. Thank you very much.
Firstly, I will thank you for the opportunity in front of such a big forum. So let me just start my slide. Is my slide visible, sir?
Yes, it is okay. Go ahead.
Yes, sir. Thank you, sir. Good evening, everyone. I'm going to talk to you about the updated robotic surgery in urology, specifically. Sorry. There's a famous saying in our local language, Tamil, so which goes by "Matram undudan maradadu," which actually translates to change is the thing only that's constant. As surgeons, we all started with the open surgery. Then came the era of minimal access surgery, the laparoscopic surgery, and currently we are in the era of so-called digital surgery, the robotic surgery. This slide shows that the various surgery that can be performed in urology with the help of a robot. Literally speaking, whatever surgery so that can be performed in by open surgery can be done with the help of a robotic surgery. Obviously, we would prefer doing it in a robot without unless and until it has some benefits. But in robotic surgery, both the patient as well as the surgeon are benefited. I'll be more elaborately talking about the technology that is available for us, which we actually can implement in our current practice. So, starting with the preoperative imaging. So, this is actually a short clip of the 3D reconstruction. So, this is actually done with the help of the CT scan images acquired and special softwares. So, with this, we can exactly identify the number of tumors, the location of the tumors. The kidney can be blurred so that the depth of the tumors can be easily identified. And moreover, the kidney can be completely blinded and know that the vasculars are supplied to the tumor and as well as the relation of the tumor to the pelvic-calcial system. Moving a step ahead, this 3D reconstruction can be actually superimposed onto the surgeon console onto the organ directly. So this is known as the augmented reality navigation system. Here in this image, we can see the assistant surgeon who actually sits beside the main surgeon in the console, and he is the person who's going to do this superimposition onto the main console. So let me just show you a typical image. So this is a case of a typically endophytically located tumor. So once we do the dissection, we defact the kidney on surface of the kidney. We are not going to have any clue of where the tumor is. But when we have this technology, we can accurately mark the tumor and open the kidney, and we can do adequate resection without any positive surgical margins. So to just to tell the advantages, so there is better understanding of the vascular anatomy. So whether we want to completely clamp the entire hilum, or we want to selectively clip the vascular supply to the tumor. So all these things helps us in our preoperative planning, and intraoperatively it helps us to look
tumor, especially when it's endophytic, and there's a higher success rate in case of complex tumors, and lesser incidence of positive surgical margins. Next is the intraoperative ultrasound. The intraoperative ultrasound, what is commonly available, is the thing that is being issued by the BK Medical. It helps us to reconfirm the tumor size, the location, especially the endophytic tumors, the depth of the tumor. Then it also enables to decide the margins of direction, margins of resection, as well as the direction of resection. So this is a small clip where we can see that renal mass, the fat has been removed over it, and then with the help of the ultrasound, we are able to identify the exact the depth of the tumor, the margin of the tumor, and its relation to the normal kidney. So with this help, we mark that tumor where we are going to cut, and we proceed with cutting the tumor with adequate margin to prevent a positive surgical margin. Another use of the Doppler part of the ultrasound probe is that whether we have achieved adequate hilar control or not. Although we do a complete proper CT with a renal angiogram, it is never 100% accurate. So there may be cases where there are accessory branches supplying the kidney and the tumor, which may not be able to identify intraoperatively. So in such cases, so this is actually very helpful. So in this video, we see the vascular supply of the tumor is very good. So, but when we achieve the hilar control, when we achieve the hilar control, the entire vascularity to the tumor is reduced, and once we release it, the vascularity reappears. This makes it sure that it is only supplied by the single vessel, or we are in complete control of the hilum, and no other accessory vessels are supplying it. Next is this novel indocyanine green. It's basically a fluorescent dye, so it emits fluorescence when the light becomes, the infrared light becomes incident, and it causes photo emission at about 820 nanometers. So traditionally, it has been used for identify the vascular perfusion and also differentiate the tissue density. In the robo, we have this tile provision and also the firefly mode. So with the help of it, we'll be able to use it. I've got some examples to show you. So ICG, it has various implications as such in urological surgeries, but more specifically, it is used for in partial nephrectomies and ureteral surgeries. So this is a case of partial nephrectomy. We have completely dissected the hilum. So ICG is given intravascularly, IV given. So the first artery becomes fluorescent, and then the entire normal renal parenchyma becomes fluorescent, but the tumor does not take up this fluorescence. So with this help, we proceed with cutting the tumor, and intermittently we keep switching between the firefly mode and the normal endoscopic mode. So here we see that the tumor has been completely resected, and the base of the tumor is also turning green, which means that the tumor has been resected with adequate margin. So So the principle why this happens is that ICG will be retained by the normal tissue in the proximal distal convoluted tubule because of the presence of a protein called the bitranslocation. So, but this is absent in the RCC and other tumors, hence they do not take up the dye. But however, if the dye is given in a larger dose, there are chances that the tumor will also take up this dye. I've got to show some more examples. So this is a case of ureteric duplication where the patient is being planned for upper moiety heminephrectomy. So it helps us identification of the ureters separately, and we'll be able to trace them. And this is a case of ureterolysis for retroperitoneal fibrosis. So it helps us completely delineate the ureter and also dissect it completely from the surrounding fibrous tissue. And in case of any damage to the ureter, it can also be identified in the form of a leak. So, and this is a case of ureteric stricture where the patient is undergoing dissection and end-to-end anastomosis. In these cases, it helps us to understand whether the vascularity at the anastomotic margin is adequate. Here we are seeing, so firstly the dye is taken up by the iliac vessels well, and also the tissue or the site of anastomosis also takes up, showing that the vascularity and perfusion is adequate. And it has certain other roles also in selective pelvic lymph node dissection, and also in case of a radical prostate where the vascularity of the urethral margin can be assessed. And this is a case of a post-transplantation where after you release the clamps to ensure the kidney gets perfused completely, so that this also can be used as a check. Next is I'll be talking very briefly about the Da Vinci single pole system, because since Dr. Somashekar has already in detail spoken about it, I would like to show you the same video. So this is the port that has been typically created for this kind of robotic system, where we can house the main endoscope and all the three working arms through it, and the entire robo is connected to the patient only via a single port. The specialty of this robo is that the instruments are more flexible at the wrist. So the range of movement of the instruments is much higher. So looking at the advantages, there's usually only one incision as demonstrated in these images. So hence a better cosmesis, the decreased pain, so that the less of hospital stay, and also the outcomes are comparable to the previous versions of the Da Vinci Robo. However, there are still disadvantages in the form that long-term data is still not available, and yes, still technical issues are there, but these technical issues are slowly being overcome by the company itself by better training of the surgeons. So this is one study I was able to find out that compares a single port robotic prostatectomy and a multi-port robotic prostatectomy. In the single port robotic prostatectomy, the entire duration of the hospital stay was very less, and also the use and the need of the narcotic analgesics is also very less compared to the multi-port surgery. In this famous study by Dr. Roni Abaza, he has shown that the incidence of daycare surgeries is more when different surgeries, like even nephroureterectomy or partial cystectomy, is higher when the surgery is being performed in a single port robo when compared to the multi-port robo. Next is the novel concept of aquablation, which has been brought by the PROCEP Biorobotics. So this is basically a modality of treatment for benign prostatic hypertrophy with the bladder outflow obstruction. This has three components. So first is the non-thermal water jet, so that there is a high pressure saline stream, so which actually cuts to the parenchyma with the hydrodissection, and it also incorporates real-time multi-dimensional truss imaging, so that we be able to accurately mark from where to where the prostate has to be resected, saving the bladder neck
ureteric orifice, and also the viru, the most importantly the sphincter. And this has been assisted by the most accurate execution of the robotic arm. So this is the typical setup of the aqua beam. So it has a BK transrectal ultrasound, and the system has 2 arms, which has a robotic arm piece on the right, and also the truss stabilization on the left. So the procedure starts with the placement of the transrectal ultrasound probe, and the hand piece has a cystoscope as well as a resectoscope, which is placed under vision into the bladder. So this is the image of the handpiece, which also has the suction aspiration as well as the irrigation ports. With the help of the transrectal ultrasound, we'll be able to accurately 3-dimensionally mark our limits of resection. And once the instrument is activated, so resection, the resection starts with the water beam, and also the prosthetic tissue, so that is being cut, will be aspirated. And finally, once our margin is reached, so the robo stops automatically, and the tissue gets collected in the suction unit. There were various studies. They are claiming to be landmark studies, that the water stool and the open water study. So based on these studies, they have shown that it is safe, and also it can be efficaciously used, and also they claim that it is non-inferior to TURP, the standard which has been the gold standard, which has been done all over the world. Looking at the main advantage, what we actually feel as a main advantage is that the firstly is a resection time. As per the literature, it is about only 10 to 12 minutes to be able to completely clear a prostate that's between 50 to 80 cc, and also more importantly, preservation of the key anatomical structures and preservation of the sexual function. However, so there are certain studies telling that in larger prostates which are measuring more than 80 cc, and especially those with a very large median lobe, the chance of complications are higher, and this instrument is obviously costly, expensive, and is not available everywhere. Next is we are looking about a robotic flexible uteroscopy for management of the intrarenal stones. Earlier, there was this Sensei Magellan system, but it's not being used nowadays. It's more of the Avicenna RoboFlex. Now, why do we need this actually robotic system? Okay, for a flexible uteroscopy, this is one of the common procedures which everyone does, and most of the surgeons does. So there has been quite some studies telling that the surgeons who do a lot of flexible uteroscopy, so they develop some orthopedic problems like the wrist issues, or the shoulder issues, or even the elbow issues. And also there's always component of radiation hazard. So there have been centers like they perform nearly 10 to 12 flexible uteroscopy a day. So amounting up to almost 300 to 350 cases a month. So this is a system where the flexible ureteroscope is completely attached to the robotic hand, and also whatever movement, so that can be that has to be done with the flexible scope, can be completely controlled by the master system, just with the help of the joystick. So looking at the advantages, this is actually performed in a ergonomically sitting position. There's no need of a lead apron because the surgeon console is well far away from the actually operating region, so that so we do not get fatigue, because generally we wear the lead apron and most of it will have to stand and then keep breaking the stone. And whatever function that has to be performed, the forward or the backward direction, all the deflections, medial or lateral dissection, so it can be just completely performed just with the help of touch screen. The laser fiber can also be moved in and out just by pushing a button. So the entire control comes in the hand of the surgeon. the speed of the irrigation can also be easily adjusted, and more importantly, the life of the endoscope and the sheath are also increased because there is no actual bending of the scope. So these are certain studies which have been done and to prove the safety and the efficacy of this technology. I was able to pick up a paper that compares the classical flexible URS versus the robotic URS. Most of the parameters, that is the treatment time, the fragmentation time, and the complications, were all comparable. In fact, looking at the outcome in terms of complete stone disintegration, the stone free rate at 3 months, and the residual fragments significantly better in the robotic group. I'm sorry. Next, is the newer surgical system that are available in the market. So we are actually looking forward to that this would break the monopoly of the Intuitive and the Da Vinci. Firstly is the Versus Robotic, the surgical robot by the CMR Surgicals. Initially, it was tried on the cadavers, and it was concluded that it can be safely used in the clinical setting. Based on this, so a large volume urological center in Pakistan have accepted to adopt this robo for the urological procedures. Next is the Hugo RAS system, which is being highly promoted by the Medtronic Robotics. So this system has actually currently approved the European CE mark approval. The first surgery, the radical prostatectomy, was performed by Dr. Alexander Moiter in the Europe. So based on this, the Canada has accepted to use this the robo for urologic surgeries. We in Chennai Apollo hospitals were the first to perform the robotic radical prostate in the entire Asia, and this is a proud team, which operates on the Hugo robotic system, and I'm extremely proud to be a part of this team. We presented our early experience on of the Hugo RAS system, and based on the cases, what we have done, we feel that this robot can effectively perform the surgeries without and without compromising the patient's safety. So how does the future go? So there are a lot of surgeries, a lot of surgical robots awaiting clearances and also in the clinical trial part across the globe. Another thing what I would like to touch about a little bit about telerobotic surgery. Although the telerobotic surgery, it came in the late 90s, it slowly faded away because of the certain technical issues, and also but looking at the overall benefits and the kind of technology of what we have now and the 5G internet, I believe it is going to be even more used in the future. And lastly, so this is a generation of all the microbots that's been coming up, and Ethicon, the Johnson & Johnson and Google, they are coming up with the autonomic robot in a very high way. So I feel and I conclude that the robotic surgery has a very bright future ahead. I would like to thank you everyone for your patient listening, and I'm open for any questions, sir.
Yes, thank you very much, Doctor. It is really, it's really impressive how the robotic is progressing. To be honest, the urology, they are the leaders of robotic, to be honest, in comparison to other specialties, maybe the gynae, but being in the top now, and you are the leader of the robotic by evidence-based. There is nobody question about the efficacy of robotic and urology, especially the prostate surgery. But what is next? Now you are on the top of the pyramid. Do you think is there anything more that more than robotic that can be achieved in the coming 10 years? Yes, go ahead.
Yes. So that's what so the microbots are being come. So these microbots are being already a pre-programmed is one, and the microboards, so which we can actually consider control the microboards. So that is another thing coming up. Another thing is that I mean, the Google and the Johnson & Johnson, they are coming up with these autonomous robots. Autonomous robots, okay, it's completely okay. We're just going to tell them what surgery is, just going to be like prefix, and it's going to just do the surgery. So it is actually okay, looking at it two ways. So one way is, as surgeons, I won't be comfortable with the autonomic robot because I'm not sure, okay, what it's doing. Another thing, okay, I'm amused at the technology what is being coming up. As I already demonstrated, this aquablation for the benign prostate. So what we do in that, we just mark the boundaries three-dimensionally, and it just cuts automatically. So what we do finally, we just go inside and we'll be just doing a check cystoscopy whether all the bleeders and everything is controlled. So that's all. So if that the same thing is going to be coming, I mean, implicated for a robotic prostate or radical nephrectomy, I don't know. As surgeons, what are we going to do?
I think should be retired soon. I'm not sure after 20 years from now how will be our surgeons, how they are going to behave, but we have to be very careful for the next generation of physicians.
Indeed, sir. Yes, sir.
Yeah, I'm really happy being with us today, Dr. Sanjay, and of course, we will have more talk in the future. You are a brilliant surgeon. You presented very nice topic. Thank you very much being with us today. Thank you.
It's my pleasure to present in front of such a forum, sir. I'm so happy for it. Thank you so much, sir.
Thank you very much. Bye.
Bye, sir.